She had saved lives in places that don't appear on any map, under conditions that would break most surgeons before breakfast. She had carried wounded men through desert heat with nothing but field dressings and will. And now, in front of 30 colleagues, a man who had never heard a bullet fired in anger looked her dead in the eyes and said she wasn't qualified to have an opinion. Nobody in that hallway said a word. Nobody moved. They all just watched. And that silence was its own kind of violence. Before we go any further, if you've never been to this channel before, hit that subscribe button right now. Every week we bring you stories like this one. Real tension, real stakes, real reversals. Hit the like button if you're already feeling it, and drop a comment telling me what city or country you're watching from. I want to see exactly how far this story travels. Now let's get into it, because what happens next in that hallway changes everything. The morning shift at Hargrove Central Medical in Raleigh, North Carolina started the way it always did, with the particular controlled chaos that passes for normal inside a Level 1 trauma center. Gurneys moved in practiced formation. Monitors beeped their rhythmic arguments. The PA system droned overhead with the flat authority of a voice that had long since stopped expecting anyone to be surprised. Nurse Lena Marsh arrived 7 minutes before her shift technically began, which was 3 minutes later than she usually did. She noticed the difference herself. She'd been up until almost 2 in the morning reviewing a patient's medication chart, not because anyone had asked her to, but because something in the numbers hadn't sat right when she left the previous evening. She'd gone home, eaten half a sandwich, pulled up the digital records on her personal laptop, and stared at the numbers until they told her what they were hiding. They were hiding something. She made a note, printed it, folded it into the front pocket of her scrubs with the careful precision of someone who had learned that paperwork, like ammunition, needed to be on your person before the situation demanded it. Hargrove Central was not a small hospital. 7 floors, 12 departments, 2 trauma bays that ran 24 hours and never fully caught their breath. The ICU sat on the 4th floor, quieter than the floors below, but carrying a heavier weight. The specific gravity of rooms where people balanced between 2 outcomes, and the margin between them was sometimes the width of a single correct decision. Lena had worked that floor for 4 years. Before that, she'd worked other places she didn't discuss at hospital socials, places that didn't come up when the conversation turned to career paths and professional development. She kept those years folded away the same way she kept the medication note in her pocket, present, accessible, but not on display. She was 36 years old, blonde hair pulled back in a tight braid that she'd worn the same way every single shift since starting at Hargrove. She was not small, but she moved quietly, the kind of quiet that comes not from timidity, but from long practice in environments where sound cost you something. Her colleagues described her variously as calm, reliable, a little hard to read. Patients adored her. She remembered things, not just medical facts, but the small human details that made a difference in a room where someone was scared and hurting. She remembered that Mr. Aldridge in 4C was afraid of the dark and kept the light on low. She remembered that the woman in 4F had a daughter named Britt, who called every evening at 7, and that the call made her mother's blood pressure drop measurably, which was better than any pharmaceutical solution in the chart. These were not things that appeared in any performance review. They were simply the way Lena Marsh understood her job. The charge nurse, Donna Reeves, caught her at the station before she'd even clocked in. "Hayes wants the full team in the conference room at 7:15. Lena looked at the clock. 7:08. "What for?" "New protocols. He's been on a tear about workflow since the board review last month." Donna kept her voice carefully neutral, which itself communicated something. "Just go in. Keep your face professional." Lena took a coffee cup from the station counter, found it empty, and set it back down. "I always do." Dr. Victor Harlan, not Hayes, she would learn the name quickly enough, was already standing at the head of the conference table when she arrived. He was the kind of man who filled a room before he started speaking, broad-shouldered, silver-templed, wearing the quiet arrogance of someone who had been told he was exceptional often enough that he'd stopped questioning it. He was the new chief of surgery, 3 months into the position, imported from a hospital system in Atlanta with credentials that the administration had circulated in a memo that read more like a press release. Lena had worked with men like him before, not in hospitals. He was speaking before everyone was seated, which told her several things at once. "I've reviewed the Q3 incident reports, and I want to be direct with all of you." He didn't look up from the tablet in his hand. There are workflow inefficiencies on this floor that are creating unnecessary friction, specifically in the area of nursing staff overstepping their designated decision scope. The room went quiet in a different way than rooms usually go quiet. There have been instances, he continued, of nursing staff escalating observations directly to attending physicians without going through proper channels. That stops. If a nurse has a concern, it goes to the charge nurse first, then to the resident. Then, if, and only if, it's deemed clinically significant, does it reach the attending. He set the tablet down and looked around the room for the first time. We are a system. Systems require structure. Structure requires everyone to understand their position in it. Lena looked at the table in front of her. She did not look at the note in her pocket. After the meeting, she found the attending physician for 4C and 4F, a resident named Dr. Patel, who was young and stretched thin and genuinely trying. She gave him the note. He read it twice, asked 2 good questions, and told her he'd flag it with the attending. It might be nothing, she told him. Might not be, he said. He folded the paper with the same care she had. She noticed that. The morning moved the way mornings in the ICU move, which is to say it moved quickly in short, violent bursts between long stretches of vigilant waiting. 2 patients needed medication adjustments. One family in 4A required 3 separate conversations before they understood what comfort measures meant, which was the part of the job that never got easier and wasn't supposed to. Lena handled each piece with the same measured economy of motion, no wasted energy, no performance. It was almost noon when Dr. Harlan came to the floor. He was doing rounds with 2 residents and the floor supervisor, a man named Gary Platt, who managed the administrative side of the ICU and had been working at Hargrove for 11 years. Harlan moved through the corridor with the momentum of someone who expected the room to rearrange itself around him, and to a significant degree, it did. He stopped outside 4D, where a patient named Mr. Vosberg had been admitted 3 days ago with what the chart described as an unusual post-surgical inflammatory response following a routine knee replacement. The inflammation had not responded to the standard protocol. It had gotten worse in a specific and atypical pattern that Lena had been noting in her shift observations since the 2nd day. She was charting near the door when Harlan stopped to review the case. Inflammatory markers are elevated, but the fever's manageable, he said to the residents, not really asking. We continue the current NSAID protocol and reassess Friday. Lena finished the line she was writing. Then she said quietly, the pattern of the inflammation is asymmetric. It's concentrated on the distal lateral aspect, and it's been progressing in a directional spread over the last 48 hours. That's not typical of standard post-surgical inflammation. The corridor went still. Harlan turned to look at her. Not the look of someone processing new information, the look of someone locating the source of an unexpected interruption. I'm sorry? His voice was not raised. Men with his particular type of authority rarely needed to raise their voices. I noticed it on the morning check, Lena said. She kept her tone even, clinical. The inflammation in 4D, it's moving. Directional spread usually indicates something other than standard post-surgical response, possibly compartment syndrome developing or an early-stage necrotizing. Nurse, he said the word like a period at the end of a sentence. Did you attend this morning's meeting? Yes. Then you understand that clinical assessments of this kind are not within your designated scope. He looked back at the chart in his hand. Mr. Vosberg is progressing within acceptable parameters. The attending's assessment stands. I understand, Lena said. I'm just saying the lateral progression in the last 2 days. I heard you. He looked up again, and this time there was something harder in it. I've been doing this for 22 years. I understand inflammatory responses. What I don't need is a floor nurse reading directional patterns into routine postoperative swelling because she's had access to a chart she's not responsible for interpreting. He turned back to the residents. Continue the current protocol. He walked away. Gary Platt gave Lena a look that was half apology and half warning and followed him. She stood in the corridor for a moment. Not frozen. She didn't freeze. She stood there the way she had learned to stand in situations that required you to hold very still on the outside while making very fast decisions on the inside. She went back to the nursing station, pulled up the patient's full chart, read through every note from the last 72 hours in sequence. Then she documented her own observation in careful, precise clinical language, the way she'd been trained, Not in any nursing program, but in a context where imprecise documentation had consequences that extended well beyond hospital administration. She saved the note. She went back to work. That's. The afternoon brought a new admission to the floor. A woman in her late 50s, a Mrs. Tarkington, presenting with acute respiratory distress that had been initially assessed in the ER as a possible pulmonary embolism. She arrived in 4G wired to monitors and already fighting the oxygen mask with the particular fury of someone who was scared and expressing it sideways. Lena took the handoff from the ER transport nurse, reviewed the preliminary workup, and settled Mrs. Tarkington's mask with a steady hand and a voice that didn't perform calm, but simply was calm, which made a difference. "You're in the right place," Lena told her. "I can't breathe properly with this thing on," Mrs. Tarkington said through the mask, her voice muffled and tight with panic. "I know, you're going to anyway, just for a little while." She adjusted the strap by 2 millimeters, a meaningless technical adjustment that nevertheless gave Mrs. Tarkington something to focus on other than her own fear. "Your daughter's here. I saw her in the family waiting area. Once we get your numbers stable, I'll bring her back." Mrs. Tarkington's monitor numbers did exactly what monitors do when a frightened person hears that their family is nearby. They moved in the right direction, incrementally, the way bodies do when the brain stops spending all its resources on terror. It was a small thing. It was not in any protocol. It was the part of the job that Dr. Victor Harlan had no framework for, and probably never had. By 4 in the afternoon, 3 things happened in close succession. First, Dr. Patel found Lena at the station and told her that the attending had reviewed her note about 4D and was not going to alter the treatment protocol, that the attending concurred with Dr. Harlan's assessment, and that she should be careful about documenting clinical interpretations that exceeded her scope because it created liability questions. Second, Mr. Vosberg's pain level spiked dramatically enough that his wife, who had been sitting quietly in the room for 2 days, came to the nursing station in visible alarm and said that something was wrong with his leg, that it looked different, that it was hard and cold in a way it hadn't been before. Third, Lena was already moving toward the room when Donna Reeves caught her arm. "Hayes, Harlan." He left a note specifically. Vosberg is not to be escalated without attending authorization. His wife says the leg is hard and cold. Donna's face changed. "How cold?" "I don't know yet. I haven't looked." A beat. Donna let go of her arm. "Go." She went. The leg was wrong. It was the kind of wrong that you either recognized or you didn't, and the recognition was immediate. The skin taut and shining over the lower limb, the color shifted from the surrounding tissue in a way that no inflammation protocol was going to address. The temperature differential under her hands that confirmed what the visual told her. Mr. Vosberg was trying to tell her with his eyes that the pain was beyond what the numbers on his patient-controlled pump expressed. She was already reaching for the call button when Harlan walked in. He had apparently been notified by Gary Platt, who had apparently been informed by Donna, which meant the information had reached him through proper channels, which was the only reason he was standing in the doorway of 4D looking at Lena's hands on his patient's leg rather than stopping her at the door. "What are you doing?" he asked. "Assessing compartment syndrome." She didn't look up. The pressure differential in the distal compartment is significant. The skin changes are consistent with early-stage acute compartment syndrome. This needs a fasciotomy consult now. "You don't make that call." "Someone needs to." She finally looked at him. "Mr. Vosberg, is the pain worse than this morning?" The man on the bed didn't have words left. He nodded once, hard, the way people nod when language has temporarily abandoned them. Harlan was quiet for 3 full seconds. Lena counted them. Then he stepped to the other side of the bed and put his hands on the leg himself. The expression on his face shifted through something she recognized. Not the shift of a man discovering he was wrong, but the more complicated shift of a man discovering he was wrong in front of an audience. He stepped back. "I'll call the surgical consult." "Thank you," she said. He didn't look at her when he left the room. The consult was called. The assessment confirmed acute compartment syndrome in the early stage, caught, as the orthopedic specialist said with the brisk matter-of-factness of someone who had seen the other outcome, in time. The fasciotomy was scheduled for 6 o'clock. By 5:30, Lena was writing up the handoff notes for the evening shift and not thinking about what had happened in 4D, or trying not to, when Harlan appeared at the end of the nursing station. He didn't approach. He stood at the far end with Gary Platt and a woman Lena didn't recognize. Administrative, by the look of her, the particular brand of neat professional dress that meant she had come from somewhere above the fourth floor. Lena kept writing. Donna materialized at her shoulder. "That's the nursing director," she said quietly. "Patricia Wohl." Lena kept writing. "Lena." Donna's voice was lower. "This isn't good." The meeting happened in the small administrative conference room off the nursing station, which could hold 6 people uncomfortably, and held 4 of them now, with the additional discomfort of what was actually being said. Patricia Wohl did the speaking. She was organized about it, which meant the conversation had been prepared, which meant this was not a spontaneous response to what had happened in 4D, but something that had been in motion before the afternoon's events had concluded. "Dr. Harlan has expressed significant concerns about scope violations on this floor," she said, "specifically regarding your conduct over the past several days. I documented an observation about a patient whose condition subsequently required emergency surgical intervention," Lena said. "You documented a clinical interpretation of diagnostic data, which falls outside nursing scope." Wohl's tone was not unkind. This, somehow, was worse than unkind. "This is not a punitive conversation, Lena. We want to support you. But Dr. Harlan has made it clear that the working relationship on this floor has become untenable in its current configuration." "What does that mean?" "It means we're asking you to take a voluntary transfer to the step-down unit on 3 while we conduct a scope review. You would retain your full position and seniority. This is a temporary measure." Lena looked at the wall above Patricia Wohl's head for a moment. Then she looked at Donna, who was staring at the table. Then she looked at Gary Platt, who was looking at the middle distance. "The patient in 4D has acute compartment syndrome," she said, "caught at the point when intervention is still possible. That happened because someone read the signs correctly." "No one is disputing the outcome, Lena," Wohl said. "Then what exactly is being disputed?" "The process." Wohl folded her hands on the table. "We have systems. Dr. Harlan's concern is legitimate. A nurse contradicting an attending physician's assessment in a public corridor creates instability in the clinical hierarchy, regardless of the outcome." Lena said nothing for a long moment. This too was something she had learned, not in any nursing program, that silence at the right moment communicated more than argument. "When does the transfer take effect?" "We'd like you to complete today's shift and transition to 3 beginning tomorrow." She nodded. Once. The way she'd nodded 100 times in rooms where the decision had already been made, and the only remaining question was how you carried it. "All right," she said. She went back to the nursing station. She finished the handoff notes with the same precision she brought to every piece of documentation. She did the medication check for Mrs. Tarkington, who was doing better, and asked after her daughter with the alert attention of someone whose body was starting to remember how to breathe normally. She sat with Mr. Vosberg's wife for 6 minutes before the surgical team arrived to prep him, not saying much, just being present in the room in the way that some people know how to be present, which is to say, without taking up space they haven't been given. At 7:15, 45 minutes past the end of her official shift, Lena Marsh walked to the elevator, pressed the button for the lobby, and rode down without looking at her phone. The lobby was quieter at this hour, the daytime volume of Hargrove Central settling into the lower register of evening. She crossed toward the main exit, the same path she took every day, the automatic doors parting in front of her with the indifferent efficiency of hospital doors everywhere. She was 10 feet from the exit when her phone vibrated. Not the personal phone. The other one, the compact encrypted device that lived in the interior pocket of her bag. The one with no apps, no photos, no personal data of any kind. The one that had been silent for 14 months. She stopped walking. She pulled it out and looked at the screen. One line of text. No sender name, no preamble. Federal medical emergency. Asset activation. Hargrove Central. Report to on-site coordinator. She stood in the lobby of the hospital she had just been reassigned out of and read the message twice. Then she put the phone back in her bag, turned around, and walked back toward the elevators. Above her, somewhere in the building she was returning to, a situation was already developing that none of the doctors on call had the specific training to understand. And somewhere in a secured convoy that had just turned off Interstate 40, A man who could not be allowed to die was being transported to the only facility within range of where he had collapsed, which happened to be Hargrove Central Medical in Raleigh, North Carolina. The elevator doors opened. Lena Marsh stepped inside. The elevator doors closed behind her and Lena stood in the small moving box of it, watching the floor numbers change, and for approximately 4 seconds, she allowed herself to feel the full weight of what the message meant before she put that feeling somewhere she could access later and return to the part of her brain that handled problems. 14 months of silence, 1 line of text, asset activation. She knew what those words meant, the way she knew the smell of a wound that was turning, not from memory she could point to, but from something deeper, the kind of knowledge that had been paid for and could not be returned. The elevator opened on 4. The floor was in the early transition of evening shift, the particular shuffle of bodies and information that happened twice a day when one team handed the weight of it to another. Nobody paid attention to her stepping off the elevator she'd stepped onto 20 minutes ago. That was one thing about hospitals. The movement was constant enough that re-entry didn't register. She went to the nursing station, found Donna Reeves still at the desk completing her own handoff documentation, and said quietly, "I need to know if there's been any communication from administration in the last 30 minutes about an incoming patient, government-related." Donna looked up. "I was literally just told to clear the isolation suite." "Which one?" 4J. A pause. "It's been cleared for 4 months. They want it operational in 45 minutes. Lena looked at the corridor leading toward 4J, which was at the far end of the floor, set apart from the other patient rooms by a secondary door that required a separate keycard and which most of the staff had gone through twice in the last year. It was the suite reserved for situations that required a level of privacy that went beyond standard protocol. Situations that Hargrove Central had a facility agreement to accommodate without asking certain questions. "Who gave the order?" "Came through the CMO's office. That's all they told me." Donna kept her voice low, the specific low of someone who understood that the conversation itself was information. "Lena, why are you back up here? They told you—" "I know what they told me." She walked toward the supply corridor without explaining further, because explanation at this point was not only unnecessary but would slow things down, and the message on the encrypted phone had said 47 minutes ago that a federal medical emergency was already in motion. She pulled the device out again and typed a 3-character reply. The code that meant received, on-site, awaiting coordination, and put it back. The supply corridor connected to the linen staging area, and from there to the equipment storage that served the isolation suites. She moved through it with the efficiency of someone who had mapped the floor not as a matter of casual familiarity, but as a matter of operational habit. She had learned the layout of Hargrove Central's 4th floor, the same way she had learned the layouts of a field hospital outside a city whose name she still did not say aloud, noting exits, sight lines, the location of equipment she might need quickly, and the structural features that would matter in a situation where normal channels had collapsed. In the equipment storage room, she pulled a crash cart inventory sheet from the holder on the wall and began checking it against the physical contents of the cart with the focused speed of someone doing this for reasons beyond bureaucratic compliance. 3 items were either expired or at minimum threshold. She pulled replacements from the shelf with the practiced reach of someone who had restocked field kits in the dark, the wrong end of exhaustion, with noise in the near distance that was not noise she wanted to think about. She was checking the defibrillator pads when the door opened. The man who came in was not medical staff. I was wearing civilian clothes, dark jacket, no visible ID, but the way he stood in the doorway for a single scanning second before entering was not civilian. She recognized it because she had once stood in doorways the same way. "Marsh," he said. "Not a question." "Yes." "I'm Coordinator Delgado. We spoke through the channel." He came fully into the room and let the door close. He was mid-40s, compact, the kind of calm that was a professional choice rather than a personality trait. "The patient is 12 minutes out. Military convoy, 3 vehicles. The situation is classified at a level that means I cannot give you specifics in this setting, but I can tell you that the patient's condition requires immediate critical care intervention and that the treating team needs to be augmented." "What's the presentation?" "Acute neurological deterioration, rapid onset. The convoy medic has been managing it for the last 90 minutes, and the patient has declined despite intervention. We have a specialist team en route, but they're 3 hours behind the convoy." "What kind of specialist team?" Toxicology. Possibly environmental exposure, possibly something else. He said it with the flat precision of someone reading from a list of uncertainties. The convoy medic thinks it's not natural progression. He thinks something accelerated it. Lena looked at the defibrillator in her hands and set it back on the cart with careful control. And why am I being contacted rather than your on-site military medical liaison? Because the on-site military medical liaison is you, he said. You've been dormant status for 14 months. The liaison position was never formally closed. She absorbed this with the specific stillness of someone absorbing information that was simultaneously a surprise and not a surprise at all. The kind of thing that exists in a category of its own. The way a door that's been locked for over a year turns out to still have your key fitting into it. Who knows I'm here? She asked. Command knows. Your hospital administration does not. As far as Hargrove Central is concerned, you are nursing staff with relevant expertise who will be assisting with a sensitive federal patient case. That framing is being communicated to the CMO now. Dr. Harlan runs this floor. Something passed across Delgado's face. Not quite amusement. More like the expression of someone who has already solved for a variable and is waiting for the equation to catch up. Dr. Harlan's role in this case will be determined by clinical need and command authority in that order. She looked at him for a moment. Then she picked up the crash cart checklist and finished the last 4 items. 12 minutes, she said. I need the convoy medic's notes transmitted to this floor before they arrive. Everything since the onset. It's already being sent. And I need someone to clear 4J properly. Not just unlocked, stocked. The isolation suite hasn't been active in 4 months, and I saw the supply inventory when I passed it. The ventilator needs its pre-use check. The arterial line setup is incomplete, and the secondary O2 regulator has a calibration sticker that expired in February. Delgado pulled out his own phone and began typing. Consider it handled. I'll handle it myself, she said. I'll know it's done correctly. She left the storage room and went directly to 4J. The suite looked like a room that had been abandoned in the middle of a task, which it had been, in a sense, cleared of its last occupant and locked without being fully reset. The specific institutional amnesia of a facility that had more immediate demands than the preparation of a room it expected to need only rarely. The ventilator was there, but its tubing configuration was wrong for immediate use. The monitor array was functional, but not calibrated to network with the central station, which meant any readings from this room would be local only unless she corrected it. The arterial line tray was stocked at about 60%, enough for a basic setup, but not for a patient whose condition might require rapid adjustments. She worked without turning on the overhead lights, using the task lighting above each station, because the overhead lights would make the room visible from the corridor window, and she didn't want an audience before she understood what she was working with. She had the ventilator retubed and tested in 11 minutes. The monitor calibration took 4 minutes because she'd done the same calibration on this same model, a different unit, a different building, a desert, a year and a half ago. And the sequence had not left her hands, even when her hands had not been asked to perform it. The arterial line tray she restocked from the supply cart she'd brought from storage, checking each item against an internal list rather than a written one. She was adjusting the secondary O2 regulator when her personal phone buzzed in her pocket. She checked it. Donna Reeves. They're here. Loading dock entrance. 2 minutes. She put the phone away and took one full breath. The specific deliberate breath that is not about oxygen, but about the transition between the state before and the state of, and walked out of 4J to the elevator. The loading dock entrance was at the back of the building, accessible through the service corridor that most of the medical staff used only for supply deliveries and the occasional administrative shortcut. When Lena arrived, 2 of Hargrove's security staff were already at the door looking uncertain in the way that people look when authority they don't recognize has arrived and they haven't yet been told whether to stand aside or assert themselves. The question resolved itself when the convoy vehicle stopped outside and the doors opened. There were 6 military personnel, 4 in uniform, 2 in civilian dress with military bearing, and a rolling stretcher that they managed with the coordinated efficiency of a team that had been trained to move equipment through difficult environments. The patient on the stretcher was male, late 50s, his face ashen in the loading dock's harsh fluorescent light, his breathing the shallow, rapid pattern of someone whose respiratory drive was compensating for something rather than operating normally. Behind the stretcher, a young man in military fatigues who was clearly the convoy medic, met Lena's eyes immediately with the focused relief of someone who has been the only medically trained person in a deteriorating situation and has just found a transfer point. "Corporal Wyatt Briggs," he said, moving to her side. "Here's the full log." He handed her a tablet with a handwritten analog backup clip to it, which told her he'd been thorough enough to maintain redundancy. She approved of that. She was already walking alongside the stretcher, reading the log in her peripheral vision while watching the patient's breathing pattern, his eye movement, the color in his lips versus the color in his hands. What was the onset? 1700 hours. He was in a meeting, standard closed room setting, and he stood up and went down. Initial presentation looked like a syncopal episode. We had him up in 3 minutes. Briggs kept pace with her, talking quickly in the flat, efficient cadence of a medic who had learned to deliver critical information without the kind of inflection that costs time. But then the neurosymptoms started, coordination issues, then dysarthria, then a brief period of altered consciousness that resolved but didn't fully clear. His speech came back, but it's degraded. He can answer questions, but his syntax is wrong. Environmental exposure? The meeting room has been flagged. Samples are being processed, but we don't have results. No one else in the room is symptomatic, which is unusual for an airborne exposure. She handed the tablet back to him. Could be contact-based, or internal, or something he was exposed to earlier and it's presenting on a delay. She looked at the patient directly. "Sir, I'm Lena. I'm going to be looking after you in the next few minutes. Can you tell me your name?" The man looked at her. His eyes were tracking correctly. That was something. "Marin," he said, and then a pause that lasted too long, and then, "Warren, Marin, Warren." He closed his eyes briefly in the specific frustration of someone who knows the right answer and is watching the wrong one come out. "That's okay," she said. "Expressive aphasia, intermittent." She told this to Briggs, who wrote it down. "What medications did you administer?" "Standard neurosupport protocol. Dexamethasone 0.15 milligrams per kilo at 1720. Ondansetron for the nausea at 1740. Nothing else. The situation wasn't clear enough for me to feel comfortable going further without more information." "Good call." They moved through the service corridor and into the elevator, a freight elevator wide enough for the stretcher plus 4 people. The rest of the convoy personnel holding position at the loading dock by some prearranged order she hadn't been part of but which made immediate sense. Delgado was already in the elevator when she arrived, which meant he knew the facility layout or had been briefed on it in advance. The elevator doors closed. Delgado looked at Briggs. "The sample processing on the meeting room. What's the estimated turnaround?" "Command said 90 minutes minimum, could be longer." "That's not helpful," Lena said. She wasn't saying it to anyone in particular. She was thinking out loud in the way she'd been allowed to think out loud in environments where the thinking was more important than the performance of certainty. "The presentation is inconsistent with a standard toxidrome. The dysarthria with intact comprehension, the selective coordination impairment, the delay between onset and the syncopal episode. It's atypical for most acute exposures." "What does that mean?" Delgado asked. "It means I want to look at the timeline of the last 72 hours. Not just what happened in the meeting room, everything. What he ate, where he was, what surfaces he touched, whether he flew in the last 3 days, whether there was any water source that was different." She looked at the patient, who was listening to this with the focused attention of someone who understood what was being said but couldn't insert himself into it. "I know that's a lot to reconstruct, but if this isn't acute environmental, it's cumulative. And if it's cumulative, the meeting room is the wrong place to look." The elevator opened on 4. Moving a government patient through a hospital floor without creating an event is a specific skill that most medical facilities are not designed to accommodate, because most medical facilities are designed around transparency, the readable flow of information that lets staff know where people are and what's happening to them. Privacy, in a standard hospital, is a curtain. It is not a vault. Hargrove Central's 4th floor was designed with a secondary access route to the isolation suites specifically because the facility agreement required it, and this is why the move from the elevator to 4J happened with less disruption than Lena had anticipated. Most of the nursing staff caught a glimpse of a government personnel escort and made the rapid institutional calculation that they did not want to be involved, which was the correct calculation. Most of the nursing staff. She had the patient in 4J and was connecting the first monitor leads when the door opened and Dr. Victor Harlan walked in. He stopped when he saw her. His expression moved through several things quickly: surprise, recalibration, a visible reassertion of authority, and then he looked at the patient and the equipment and the government coordinator standing against the wall and the military medic reading from a tablet in the corner, and he looked back at Lena. "This is my floor," he said. "I know." She didn't look up from the leads. "Who authorized you to be in this room? You've been transferred to—" "Dr. Harlan." Delgado stepped forward. He produced an ID, the specific kind of ID that is not from a hospital system, and held it long enough for Harlan to read it, but not long enough for him to study it. "This patient is under federal medical jurisdiction. Nurse Marsh has been requested by name to participate in the care team for this case. This supersedes internal staffing decisions." Harlan looked at the ID, then at Lena, then at the patient. "What's the diagnosis?" he asked, and to his credit, his voice had shifted. Not all the way, not to anything approaching humility, but the leading edge of the authority had pulled back and something more cautious had taken its place. "Working on it," Lena said. "I can be useful here. Neurology isn't my primary specialty, but we'll let you know if we need additional attending coverage," Delgado said, and the politeness in his voice had the specific quality of a locked door that has been painted to look like a suggestion. Harlan stood in the room for another 3 seconds. Then he left. The door closed. Briggs looked at Lena across the patient's bed. "That happen a lot here?" "More than it should," she said. She turned back to the monitor, which was now displaying the patient's vitals in real time, and the picture was not encouraging. The heart rate was stable, but the oxygen saturation was trending down in the slow, deliberate way that means the body is losing a fight. It's trying not to show. The blood pressure was holding, but with an asymmetry between readings that she noted and flagged in the chart she was building in parallel. Not the hospital's electronic system, which she had been locked out of as part of the transfer process, but a parallel documentation on the secure tablet Delgado had brought. She was being asked to care for a patient in a hospital where she had just been demoted and locked out of the clinical record system, using equipment she'd set up herself, in a room that hadn't been operational 4 hours ago, while working from the field notes of a corporal who was 19 years old at most and had been alone with a deteriorating VIP for 90 minutes. She had worked in worse conditions, significantly worse. "Briggs," she said, "the dysarthria. Did it get better or worse during transport?" "Better after the dexamethasone. Then it plateaued. Then about 40 minutes ago it started getting worse again." "Worse how?" "He stopped trying. For about 15 minutes he just stopped talking. Then it came back." She looked at the patient. He was watching her with the steady eyes of a man who was accustomed to being the most informed person in a room and was currently experiencing the specific discomfort of not being that. She understood the feeling from the outside and also, in small pieces, from the inside. "Mr. Warren," she said, using the name Briggs had recorded in the convoy logs. She spoke clearly, not loudly. Volume was not the issue. "I wanted to ask you some questions, and I want you to answer them however you can. Nod, point, one word, whatever works." He nodded once. "In the last 3 days, have you been anywhere that had a different water source than your usual? A different building, a different city, somewhere that required you to drink or cook with a water supply you don't normally use?" A pause, then a slow nod. "Where?" He opened his mouth, tried. A sound came out that was not a word, and the frustration that crossed his face was the most expressive thing she'd seen from him since he'd arrived. He closed his eyes, opened them, looked at Briggs. Briggs said, "He was in Asheville for a briefing the day before yesterday, conference facility outside the city. He stayed overnight." "Was that lodging different from his usual?" Briggs checked the log. "Private residence. A department liaison property." She wrote that down. "Okay." She looked back at Warren. "Were there any other people at that property overnight?" He held up 2 fingers. "2 other people?" A nod. "Are they symptomatic?" A long pause. He didn't know. The pause itself was information. He hadn't been in contact with them since, or the communication had been severed, or he genuinely didn't know, all of which were worth knowing. Delgado was already on his phone in the corner, speaking quietly, but with the focused urgency of someone who had just received a new variable and was plugging it into an existing equation. Lena stepped back from the bedside and pulled the timeline she'd been constructing in her head into a rough linear form. Not written, not yet, because writing it down made it a record, and she wasn't ready to commit to a diagnosis she couldn't yet defend. But the shape of it was there. Exposure at the liaison property 2 days ago. Latency period of approximately 30 to 36 hours. Onset at the meeting. Progression that was chemical in character rather than infectious in pattern. The asymmetric blood pressure readings that suggested something vascular rather than purely neurological. The response to dexamethasone that had dampened but not resolved the presentation. She had seen something close to this once. Not identical, but close. Not in a hospital. She needed the environmental samples from the liaison property, not the meeting room. She needed them faster than 90 minutes. She needed to know whether the other 2 people who had stayed at that property were still healthy, and she needed that answer in the next 20 minutes, not later, because if they weren't, the differential narrowed dramatically, and the treatment protocol changed in a direction that the current setup in 4J was not fully equipped to support. She turned to Delgado. The other 2 individuals from the Asheville property, can you get a wellness check on them right now? He was already nodding, already moving the call in that direction. She turned back to the patient, checked the O2 saturation, made a micro adjustment to the flow rate that brought the number up by 1 point, not enough, but directionally correct, and was reaching for the arterial line setup when the door to 4J opened again. This time, it was not Harlan. It was a woman in a dark suit who carried herself with the specific gravity of someone who was accustomed to walking into rooms where the existing hierarchy rearranged itself around her arrival. Behind her were 2 uniformed Army personnel, and behind them was Donna Reeves looking like a woman who had been swept along by a current she had not anticipated. The woman stopped just inside the door, and her eyes moved across the room. The patient, the equipment, Delgado, Briggs, and landed on Lena. "You're Marsh," she said. "Yes." "Colonel Diane Strickland, Army Medical Corps. I need a status update, and I need it in 30 seconds. Lena gave it in 25. What? Vitals. Symptom progression. Differential working hypothesis. The Asheville property is likely exposure point. The sample processing gap that was the current critical bottleneck. The immediate treatment question that depended on the wellness status of the other 2 individuals." Strickland listened without interrupting, which was its own kind of evaluation. When Lena finished, Strickland looked at Delgado. "The other 2 are already being checked. Results in 10 minutes. Then she looked back at Lena with an expression that was not warm but was precise. The expression of someone calibrating an asset they hadn't expected to be this operational. "You've been on this floor how long?" 4 years at this facility. "And before this facility?" A beat. "That depends on the clearance level of the conversation." The corner of Strickland's mouth moved. Not quite a smile. Something adjacent to one. "I have it." She looked at Briggs, then at the patient, then back at Lena. "What do you need right now that you don't have?" "The environmental sample results from Asheville. Faster than 90 minutes. Lena held the colonel's gaze. "And I need access to this patient's electronic health record within this hospital's system. My access was revoked this afternoon." Strickland turned to Donna Reeves, who was still standing near the door with the look of someone watching a play in which she had unexpectedly become a supporting character. "Who revoked her access?" Donna said carefully. "Dr. Harlan initiated a scope review." "That's not what I asked." "Dr. Harlan." Strickland looked at the 2 uniformed personnel behind her. One of them nodded and stepped out of the room. The other remained. Lena turned back to the patient. She was checking the arterial line setup, her hands moving through the preparation with the muscle memory of 100 similar setups, when her tablet, the hospital issued one that had shown her access as revoked for the past 3 hours, suddenly populated with a new patient chart. Patient, Warren, G. Federal jurisdiction case. Access granted, Marsh, L.R.N. She looked at it for a moment. Then she opened it and began entering the documentation she'd been building in parallel for the last 40 minutes. Behind her, Strickland said to Delgado, in a voice that was not lowered but was not intended for the room, "She went through all of this and nobody here knew what they had?" Delgado said something she didn't catch. She didn't need to catch it. She had a patient in front of her whose neurological function was declining in a pattern she had almost identified, a treatment decision that hung on information that was 9 minutes away, and a room full of people who were starting to understand that the nurse who had been transferred off this floor 7 hours ago was not who they had thought she was. The O2 saturation dropped 2 points. She adjusted the flow, watched the number, waited. It did not come back up. She looked at Briggs. What was his baseline sat before onset? 98. She looked at the monitor. 91 and falling. Strickland. Her voice was level, but it carried. I need to know about those other 2 individuals right now, because if they're symptomatic, I need to change this treatment protocol in the next 4 minutes. And if I'm wrong, I have 1 shot to correct it before his respiratory drive. Strickland was already on the phone, speaking fast, listening. Her face did not change, but something in the set of her jaw did. She lowered the phone. Both symptomatic, she said. Onset approximately 6 hours ago. Both currently in emergency transport. The room went very quiet. Lena looked at the patient, at the monitor, at the arterial line in her hand. Okay, she said. And then she started moving. The protocol change took 11 seconds to decide and 4 minutes to execute, which was 11 seconds longer than she would have liked, and 4 minutes faster than anyone else in that room could have managed. She knew what she was looking at now. Not completely. She wasn't willing to say completely because the sample results weren't back, and she had learned in environments considerably less forgiving than a hospital ICU that the word completely was a liability. But enough. The combination of the bilateral symptom pattern, the delayed onset, the selective aphasia with preserved comprehension, the asymmetric pressure readings, and now the confirmation that 2 other individuals who had shared the same overnight lodging were presenting with the same progression on a 6-hour lag told her that this was not a toxin released in the meeting room. Whatever had been introduced at the Asheville property, absorbed slowly, and was now metabolizing into something that the dexamethasone had slowed but not stopped. The treatment shift required pulling 2 medications from the crash cart she'd restocked, adjusting the IV line configuration, and making a call about the oxygen delivery method that had a margin for error she did not enjoy thinking about. She made the call anyway because not making it was also a call, and the worse one. Briggs. She didn't look up from the IV setup. The dexamethasone. What was the exact infusion rate? He read it from the log without hesitation. She adjusted accordingly, working the math in her head, cross-referencing against the patient's weight from the convoy intake form because the hospital hadn't processed an admission yet in any meaningful sense. The system still generating automatic flags about an unregistered patient in 4J that someone in administration was presumably panicking about. Strickland was watching from the foot of the bed with the contained attention of a person who understood enough medicine to follow what was happening but was smart enough not to insert herself into the execution of it. The patient, Warren, had his eyes open and fixed on Lena with an expression that was concentrated and afraid, and trying very hard not to show the afraid part. She recognized that expression. She had seen it in a dozen different contexts, on a dozen different faces, in places where showing fear was correctly understood as a strategic disadvantage. You're still with me, she told him. Not a question. I've adjusted what you're getting, and I want you to tell me in about 3 minutes if the pressure behind your eyes changes. Can you do that? He nodded. Just nod or shake. Don't try to word it. Another nod. Smaller. More effort behind it. She moved to the monitor array and pulled up the waveform display that showed the real-time arterial pressure trace, the one she'd set up to run through the military-grade peripheral line Briggs had placed during transport, which was better than anything she could have accessed through the hospital's standard IV protocol. The waveform was irregular in a specific way, the dichrotic notch blunted in a pattern that fit the hypothesis she was building. It fit it too well. She had a new thought, unwelcome and precise, and she turned it over twice before she said it. Strickland. The colonel was at her side in 2 steps. Lena kept her voice low enough that it didn't reach Briggs or Delgado or the uniformed personnel near the door. The blunting in this waveform is vascular, not just neurological. If what I think this is what this is, it's not one agent, it's 2. Something that crosses the blood-brain barrier and something else that's working on the vasculature. The dexamethasone addresses the inflammatory component of the first one. It does nothing for the second. Strickland looked at the waveform. She was not a civilian looking at a confusing display. She looked at it with the focused comprehension of someone who had seen this kind of monitoring before. What do you need for the second component? That depends on what it is, and right now I don't know what it is. She paused. But the sample results from Asheville aren't going to tell me either, because if it's a vascular agent and it was introduced through the water supply or a contact surface, it may not flag on a standard environmental panel. It's going to look like trace contamination. So what tells you? His history. Specifically, his medical history. She looked at Strickland directly. I need to know if he has any pre-existing vascular conditions, any medications he takes regularly, anything that would interact with an exogenous vasoactive agent in a way that amplifies the presentation. His medical record is classified. I understand that. Classified above my clearance level. Lena absorbed this. Then I need someone who has that clearance, right now, on the phone or in this room. Strickland looked at her for a moment with an expression that was recalculating something, not Lena's credibility, which appeared to have been established to the colonel's satisfaction, but the operational geometry of a situation that kept acquiring new constraints. She stepped back and made a call. Lena went back to the patient. The 3 minutes she'd asked Warren for had elapsed. She looked at him with the specific silent question of someone who has learned to communicate efficiently without words, and he gave a small, slow shake of his head. The pressure behind his eyes had not changed. Okay, she said. That's information. It was not good information, but it was honest. And honest information was always more useful than comfortable information. The saturation had stabilized at 92. Not good, not deteriorating. A pause in the wrong direction that might mean the medication adjustment had bought time, or might mean the body was redistributing its available resources in preparation for a more significant decline. She had been in enough acute situations to know that stability could be a plateau or a ledge, and you often couldn't tell which until you were already past it. She was checking the fluid balance when the door opened and Harlan walked back in. He was not alone this time. He had Dr. Patel with him, and behind Patel, Gary Platt, and behind Platt, a woman in administration scrubs that Lena did not recognize. Harlan's face had the particular expression of a man who had spent the last 40 minutes being progressively told things he did not want to hear and had arrived at the decision that the solution was to reassert control of the situation physically. This is my patient floor, he said, and this time his voice had more force in it. And I will not be excluded from... Doctor. Strickland stepped in front of him with the unhurried precision of a traffic barrier that has no opinion about whether you'd prefer it wasn't there. She was several inches shorter than Harlan, and the height difference appeared not to concern her at all. I've explained the jurisdictional situation to your CMO. If you'd like to review the federal facility agreement, I've seen the facility agreement. It covers secure patient admission. It does not give the Army the authority to remove my surgical staff from... Your surgical staff was not removed. Strickland's voice had not changed in volume or temperature. A staffing decision made by your hospital administration has been temporarily superseded by clinical need. That is within the agreement's scope. She's a floor nurse. He said it the way he'd said you're just a nurse in the corridor that morning, with the same absolute certainty that this description was sufficient argument. She was under scope review for clinical overreach this afternoon. Whatever her background, Strickland said, is the reason this patient is still breathing at the saturation level he's currently maintaining. The room went quiet in a way that had weight. Patel, near the door, looked at his shoes. Platt looked at the wall. The administration woman looked at Harlan with the expression of someone who had suddenly become aware that she was standing in a room where the wrong person had been speaking with the most authority for longer than was defensible. Harlan stood his ground for another 3 seconds. Lena counted them, the same way she'd counted them in the corridor. Then he looked past Strickland at the patient, at the monitor array, at the IV configuration, and something moved through his face that was not the recalibration of authority this time, but something older and less comfortable. He looked at what Lena had built in this room in under 2 hours, starting from a suite that had been dark and improperly stocked, and he looked at the man in the bed who was alive and cognitively present and being carefully managed, and he could not find a clinical argument because the clinical argument was in front of him and it was working. He left without speaking. Platt followed. The administration woman followed. Patel lingered at the door for a moment and looked at Lena with an expression that was complicated and genuine. "The note you gave me this morning," he said, "about Vosburg. I should have pushed harder." "He's okay," she said. "That's what matters." Patel nodded and left. The sample results from Asheville came back at 9:47, 43 minutes faster than the projected 90-minute turnaround, which meant someone with significant authority had made a call. Strickland took the transmission on her tablet and handed it to Lena without comment. Lena read through it standing up, because sitting felt like the wrong allocation of posture for what she was doing. The panel was exactly what she'd expected, which was the problem. The environmental results from the liaison property's water supply showed trace markers that a standard panel would categorize but within acceptable variation. Not flagged, not alarming, the kind of result that gets filed and forgotten. But she was not reading it as a standard panel. She was reading it with the specific interpretive lens of someone who had spent 8 months attached to a unit whose primary operational concern was exposure events in environments where the exposure was designed to look like nothing. She knew what legitimate trace variation looked like in a water supply. She knew what introduced trace variation looked like when it was constructed to fall below reporting thresholds. The difference was not in the chemicals themselves, but in their ratios. The specific relationship between two compounds that should have no reason to appear together in any natural or accidental contamination scenario. She looked at Strickland. This is intentional. The word landed in the room with the specific gravity of a diagnosis that changes the category of everything that came before it. You're certain, Strickland said. It was not a question with doubt in it. It was a question that was asking her to confirm that she understood the weight of what she was saying. The compound ratio in the water sample is not an accident, and it's not industrial runoff, and it's not a contaminated supply line. She set the tablet down. Someone introduced this, and they did it in a concentration specifically calibrated to look like nothing on a standard panel, while producing cumulative neurological and vascular effects over 30 to 48 hours. The uniformed personnel at the door had gone very still. Delgado, who had been on his phone in the corner for the last 20 minutes, was no longer on his phone. He was looking at Lena with an expression that had moved past operational assessment into something she would have described, if she were being precise, as concern. What's the second agent? Strickland asked. I can't confirm without a full tox panel that specifically targets synthetic vasoactive compounds. Standard tox isn't going to catch it. You need a specialized screen. She paused. And you need it done somewhere with the equipment to run it, which this hospital does not have. How long can you maintain him without knowing? She looked at Warren. His saturation was still 92. His heart rate had climbed 3 beats per minute in the last 20 minutes, which was a small number with implications she didn't like. I can manage the inflammatory component with what I have. The vascular component, she stopped and restarted. If the second agent is what I think it is, it's going to produce a pressure event in the next 4 to 6 hours. I can delay it. I cannot prevent it without knowing exactly what I'm dealing with. 4 to 6 hours, Strickland repeated. Conservative estimate. Could be sooner. Strickland made 3 calls in 6 minutes. Lena listened to enough of them to understand that the specialized toxicology equipment was being transported from a military medical facility that was approximately 2 hours away, that the facility was aware this was time-sensitive, and that someone above Strickland's rank had been briefed and had given an authorization that made things move faster, which meant that in 2 hours she would have what she needed. In 2 hours she might also be past the window in which she could use it. She adjusted Warren's fluid rate, recalculated the medication timing, and rebuilt the treatment sequence in her head to account for a 4-hour rather than a 6-hour window, which was the more honest estimate, and the one she was not saying aloud in this room, because a room full of people being told they have 4 hours instead of 6 behaves differently than a room being told 6, and she needed this room to function. Briggs, she said. The young corporal appeared at her elbow. He had been quiet for the last 30 minutes, maintaining his position with the disciplined patience of someone who understood that staying out of the way was its own form of contribution. You said he stopped talking for 15 minutes during transport, before it came back. Yes. Was there anything that happened in the 15 minutes before it stopped? Any change in position, in the vehicle's movement, in the temperature? Briggs thought about it with the seriousness of someone who understood that the question was not casual. We hit a rough section of road. About 50 miles outside Raleigh, he was jostled pretty significantly. Did his symptoms change immediately after the jostling, or was there a delay? Delay. Maybe 3 minutes. She wrote it down. The 3-minute delay between a physical perturbation and a symptom change was consistent with a vascular mechanism, specifically with a pressure-sensitive response that suggested the second agent was affecting vascular tone in a way that was sensitive to perfusion changes, which was both informative and alarming because it meant that any significant change in Warren's blood pressure, up or down, could accelerate the timeline. She looked at the current blood pressure display. 142/88. Elevated. Not crisis level elevated, but trending. She adjusted the positioning of the bed, raising the head by 15 degrees, and watched the pressure trace for 2 minutes. The systolic came down by 4 points. She accepted 4 points. 4 points was something. Warren was watching her work with the same focused attention. His eyes had been tracking her consistently for the last hour, not the unfocused tracking of someone whose consciousness was degraded, but the deliberate attention of someone who was evaluating the person managing their life and had arrived at a provisional conclusion that she could be trusted to do it. He raised one hand from the bed, slowly. She looked at him. "What do you need?" He pointed at her, then made a writing gesture with his other hand, then pointed at the wall where his chart was displayed. "You want to know what's in the chart?" A nod. She pulled a stool to the bedside and sat, which put her at eye level with him rather than above him, which she had learned a long time ago, made a difference in how people heard information that was difficult. "The environmental exposure that's affecting you was introduced deliberately," she said. "We believe it was at the property in Asheville. The 2 other people who were there with you are symptomatic and being transported to medical facilities now." She watched his face. "Do you know what I mean when I say introduced deliberately?" His jaw tightened. He knew. "I have a partial picture of what it is. I'm managing the piece I can identify while we get confirmation on the second piece. You're stable right now. Not great, but stable, and that's a real thing." She paused. "The next 4 to 5 hours are going to be the hard part." He looked at her for a long moment. Then he did something she didn't expect. He almost smiled. Not a full smile. His face wasn't cooperating with full expressions right now, but the ghost of one. The specific expression of someone who has been in enough hard situations to have developed a dark appreciation for honest delivery. She stood up. "Try not to worry about anything except breathing normally." He made a sound that might have been a short laugh. At 11:15, the floor shifted in a way that Lena registered before she consciously understood why. The particular change in ambient sound and movement that meant something significant had arrived on the floor or was about to. She had learned to read buildings the way she had learned to read terrain, not by looking directly at the thing, but by watching how everything around it responded. She stepped to the door of 4J and looked through the narrow window panel into the corridor. There were 4 new people she hadn't seen before, moving with the purposeful economy of people who knew exactly where they were going. 2 of them were in uniform, senior insignia, not the level of Strickland's rank, but above the personnel who'd been stationed at the door. The 3rd was in civilian dress with the same tells as Delgado. The jacket, the posture, the scanning habit. The 4th was a woman in her late 50s, civilian clothing, no visible ID, moving at the center of the formation with the particular authority of someone who is not being protected by the people around her, but simply accompanied by them because they happen to be going to the same place. Strickland, who had been on the phone near the window, came to stand beside Lena. She said nothing. The woman at the center of the formation pushed open the door to 4J and walked in. She looked at the patient first, then at the equipment, then at Strickland, then at Lena, with the direct and unhurried attention of someone for whom taking a full measure of a person was not a social act, but a professional one. "You're Marsh," she said, the same words Strickland had used 4 hours ago. The same way, not a question. "Yes." "Brigadier General Paula Kren." She didn't offer a hand, which, in the specific context of a biosecure patient room, was correct protocol, and also communicated something about her understanding of environments like this one. "I've been briefed on the situation here." She looked at the monitor, then back at Lena. "I understand you identified a compound exposure that the environmental panel missed." "Yes." "Walk me through it." Lena walked her through it. She did it in 4 minutes. The timeline, the compound ratio interpretation, the dual agent hypothesis, the vascular mechanism, the treatment adjustments, the estimated window. She spoke in clinical language because Kren was following it without visible effort, which meant she either had a medical background or had spent enough time in medical situations that the language was familiar. When Lena finished, Kren was quiet for a moment. The specialized tox equipment arrives when? Estimated 11 minutes, Strickland said. And without confirmation of the second agent? I'm managing it symptomatically, Lena said, delaying the pressure event. But I'm working with incomplete information, which means I'm making conservative adjustments when some situations might call for more aggressive ones. I don't want to overshoot in the wrong direction. Kren looked at her with an expression that Lena recognized. Not from hospital settings, but from briefings. From situations where a decision-maker had received a technical assessment from a specialist and was in the process of determining whether to trust it. It was the expression of someone who had to choose between deferring to expertise they couldn't fully evaluate and acting on their own judgment in a domain that wasn't theirs. Kren deferred. You have what you need in terms of authority. Anything you require in this hospital is available to you. I need Dr. Harlan to understand that, Lena said. She said it without aggression, as a logistical observation. Not because of what happened today, but because if the next 4 hours require rapid decisions, I can't be slowed down by jurisdictional arguments at the wrong moment. Kren looked at Strickland. Something passed between them, brief and sufficient. Understood, Kren said. She moved to the bedside and looked at Warren with the expression of someone who knew him and was concerned in a way that was personal rather than official. She spoke to him quietly for less than a minute. Lena moved away to give the conversation its appropriate distance, and then she stepped back and her face resumed the expression of professional authority, though with something behind it that hadn't been there before. The tox equipment arrived at 11:23, carried in by 2 lab technicians from the military medical facility who moved like people who had made fast emergency transports before and had the bruised efficiency of it. They set up in the corner of 4J that Lena had cleared for exactly this purpose when she'd first prepped the room, which was not something she could have anticipated. She'd cleared it out of spatial habit, the operational instinct to always maintain a work area, and she felt a sharp particular gratitude for the habits that didn't require conscious application. The specialized tox screen took 19 minutes. She watched it run with the specific patience of someone who knew that watching did not accelerate results, but had learned to keep the anxiety of waiting on the inside where it couldn't affect the people around her. Briggs had fallen asleep on his feet near the door, leaning against the wall with his arms crossed in the posture of someone who had trained himself to rest in positions that looked like standing. She let him sleep. He'd done his job well, and the next phase was not his to carry. Warren's pressure trace had made 3 small adverse movements in the last 40 minutes, each correcting itself within 2 to 3 minutes. She adjusted the fluid rate twice and the medication timing once. The adjustments were conservative, targeted, and held. She was aware that this was the kind of clinical tightrope that looked, from the outside, like controlled management and felt, from the inside, like standing at the edge of something and making very small movements to stay on the right side of it. The equipment produced its readout at 11:42. She read it once through quickly, then again slowly, then a third time to confirm that she was reading what she thought she was reading. She was. The second agent was a synthetic vasoconstrictor, modified in a way that suppressed its standard pharmaceutical markers while preserving its mechanism, designed to accumulate in vascular smooth muscle tissue over 36 to 48 hours before triggering a cascade that would present as a spontaneous hypertensive emergency. On a clinical workup, it would look like a cerebrovascular event. On an autopsy, it would look like a pre-existing condition that had finally expressed. The compound modification was sophisticated, not something available through any commercial or academic chemistry route. She held the readout and thought about what it meant for approximately 4 seconds. Then she thought about what it meant for treatment, which was a different and more immediately useful question. There was a pharmacological intervention, a combination of 2 drugs, both present in Hargrove Central's formulary, that would bind to the modified compound's receptor sites and arrest the cascade before it reached the pressure threshold. She was reasonably confident of this. She was not completely confident because the compound modification meant the standard dosing models were not directly applicable, and she would be extrapolating from mechanism rather than from established clinical data. She had extrapolated from mechanism before, in conditions that had not provided the option of caution. She brought the readout to Strickland and Kren and explained the intervention in the same 4-minute clinical language she'd used before, and then she said, I need authorization to proceed. The intervention carries a risk of overcorrection. If I misjudge the dosing by more than about 15% in either direction, we create a different problem. But the alternative is waiting for the cascade to reach threshold, at which point we're managing a crisis rather than preventing one. Kren looked at the readout, then at Warren, then at Lena. What's your confidence level? High enough that I'm recommending it, not so high that I'm pretending there isn't a margin. How long do we have before we lose this prevention window? Lena looked at the pressure trace, at the time, at the last 3 adverse movements and the intervals between them. 90 minutes, maybe less. Kren said, "Do it." Lena was already moving to the medication locker. She pulled the 2 drugs, calculated the dosing from the modified mechanism parameters, drew the first syringe with a steadiness that was not confidence but practice, and was preparing the second when Strickland said quietly, Marsh. She looked up. The property in Asheville. The compound modification. This took significant resources to produce and introduce. Strickland was looking at the readout. Someone with access to that property prepared this over a significant period of time. Yes. That means this wasn't opportunistic. No, Lena said. It wasn't. They held that knowledge between them for a moment. Then Lena turned back to the syringe and finished preparing it. The implications of what Strickland had said were real, and they were significant, and they belonged to a different category of problem than the one currently in front of her, which was a man with 90 minutes of prevention window and a nurse with 2 syringes and a dosing calculation that needed to be right. She administered the first component of the intervention at 11:51. She watched the arterial pressure trace for the next 3 minutes without looking away. The trace made one small adverse movement at minute 2. Her hand moved to the second syringe. And then the door to 4J opened, and the person standing in the doorway was not Harlan, not Platt, not anyone she'd encountered in this building or in the previous 4 hours of this situation. It was a man in civilian dress, mid-40s, Hargrove Central ID badge at his lapel, and the first thing she noticed was that the ID badge had the wrong date on it, not expired, wrong. And the second thing she noticed was that he was looking not at the patient or the equipment or the military personnel, but at the tox equipment readout screen, which was still displaying the compound identification results. The third thing she noticed was that Delgado had his hand at his jacket before the man had taken a second step into the room. "Stop," Delgado said. The man stopped. The room snapped to a different kind of attention, the kind that has nothing to do with medicine. Lena looked at the pressure trace. The adverse movement was holding at the same level, not progressing, not resolving. She had approximately 4 minutes before she needed to make a decision about the second syringe regardless of what was happening at the door. She looked at the man. He was looking at the readout screen with an expression that had moved past the neutral performance of a hospital employee into something stripped of it. He knew what was on that screen. He knew what it meant. And he knew now that she had read it. Her hand was on the second syringe. Her eyes were on the pressure trace. The room held its breath. Delgado moved first, and he moved the way people move when they have been trained to close distance faster than the other person can make a decision about it. Not running, not lunging, just suddenly present at the man's side with a grip on his jacket collar that was firm enough to be unambiguous and controlled enough to communicate that this was the professional version of what could otherwise be considerably less comfortable. The man did not resist. That was the first thing that was wrong about it. People who walk into secure rooms by accident resist when grabbed, because the grabbing is a surprise and the body responds to surprise before the brain can intervene. People who walk into secure rooms on purpose and are caught doing it sometimes resist and sometimes don't, and the ones who don't are making a calculation. The calculation that resistance makes things worse and compliance creates options. This man went completely still in Delgado's grip with the immediate practiced quality of someone who had made that calculation before and knew exactly where it led. Lena had 4 seconds to observe this before she had to look back at the pressure trace. The adverse movement had not resolved. It had held at the same level for 6 minutes now, which was longer than any of the previous 3 adverse movements had held, which meant the first syringe had slowed the mechanism but had not arrested it, which meant the dosing had been conservative enough to be insufficient, which meant she needed to make a decision about the second syringe before the trace moved again. She administered the second component at 11:56. The room behind her was doing things she was not looking at. She could track it peripherally and through sound. Delgado's voice, low and authoritative, asking for identification. The absence of the man's voice in response, which was itself a response. Kren, somewhere near the door, speaking into a phone in the compressed, urgent language of someone reporting a security breach to a party who needs the information immediately and without narrative. The two uniformed personnel shifting position with the quiet, controlled movement of people who have just reclassified the threat level in the room. She watched the trace. 90 seconds after the second component, the line smoothed. Not dramatically, not the clean resolution of a textbook intervention, but the specific rough reduction of a system that has been fighting something and has had that something partially neutralized. The adverse movement began to retreat, slowly. The systolic came down in increments that required patience to read. 3 minutes, 4, 5. At the 6-minute mark, the trace was within a range she would describe as guarded but controlled. Not good. Controlled. She exhaled through her nose, which was the only version of relief she allowed herself when the work was not finished. She turned around. The man was against the wall near the door, Delgado beside him. The two uniformed personnel positioned in a way that made the geometry of the room very clear about where the exits were and who was managing access to them. The man's face was composed. His hands were at his sides. The Hargrove Central ID badge at his lapel was the wrong date, and she could now also see that the photo on it was slightly misaligned with the laminate. Not wrong enough to catch at a glance in a busy hospital corridor, wrong enough to matter under direct scrutiny. She walked to where Delgado was standing and looked at the ID. "That's a fabrication," she said. "The photo laminate is off, and the date format is wrong. Hargrove uses a 4-digit year code. That's 3 digits. Delgado looked at it. He had already known this. He was looking at it again with the focused attention of someone cataloging evidence. "Yes." She looked at the man. He was looking back at her with an expression that had finally settled into something honest, stripped of the performance of a hospital employee who had taken a wrong turn. What was underneath it was not fear exactly. It was the particular flat affect of someone who has been caught at the thing they were doing and is now running a separate internal process about what comes next. "The readout screen," she said. "You came in here because someone told you what would be on it." He said nothing. "You weren't sent to stop the treatment. You were sent to see how much we knew." She said it to Delgado rather than to the man, because it was more useful as information for Delgado than as an accusation pointed at someone who wasn't going to respond to it. Which means whoever sent him is running a secondary assessment. They already knew the primary exposure failed. Delgado looked at her. "Why failed?" "Because he's alive and cognitively present, and we have the compound identified and characterized." She glanced at Warren, who was listening to this exchange with the steady attention that she'd come to recognize as his baseline, absorbing everything, filing it, saying nothing unless he could say it usefully. If the exposure had worked as intended, there would be nothing to identify. The failure changes their posture. They're gathering information now, not executing. Kren ended her phone call and crossed the room to them. She looked at the man against the wall. "Who sent you here?" "Nothing." "That's all right," Kren said. "We'll have the answer through other channels before morning." She was not wrong, and the man appeared to know she was not wrong, because something in the flat composure shifted slightly. Not breaking, not quite, but the hairline fracture of a held position. Delgado took the man out of the room with the assistance of one of the uniformed personnel, and the door closed, and the room was briefly quieter and then immediately busy again as Lena moved back to the bedside, and the remaining personnel redistributed themselves, and Kren made 2 more calls in fast succession. Briggs was awake. She didn't know when that had happened, but he was standing straight near the window, watching the tray of tox equipment with the alert expression of someone who had processed the last 15 minutes while appearing to be elsewhere. "You should get something to eat," she told him. "I'm fine." "That wasn't a question about whether you're fine. You've been running on transport adrenaline for 6 hours. She didn't say it harshly. "There's a break room at the end of the corridor, 15 minutes. He hesitated. "The patient. I'm here." He left. She turned back to the trace. At 12:40 in the morning, Warren's oxygen saturation reached 94 for the first time since admission and stayed there for 11 consecutive minutes, which was the first sustained improvement rather than a temporary fluctuation, and which Lena recorded in the chart with the careful precision of someone writing down a fact they want to be able to point to later. His blood pressure was 138/84, still elevated, moving in the right direction. The dysarthria had not resolved. The speech production impairment was a separate mechanism from the vascular component and would require a longer recovery timeline. But when Lena asked him to rate his pain on the standard 1 to 10 scale, using his fingers, he held up 3 fingers and then reconsidered and held up 2, which communicated not just the number but the cognition behind it, the second guessing that required comparison and revision, and was the cognitive operation most disrupted by expressive aphasia when it was severe. 2 fingers. She wrote it down. She also wrote down the revision process, because that was the more important data. She was updating the chart when the door opened and Harlan walked in again. She had been expecting this, in the way that she expected structural events, not because she could see them coming, but because the logic of the situation made them predictable. He had been told to stand down by Strickland and then by implication by Kren, and he had stood down because those were not people you argued with in the short term, but the short term had a limit, and at 20 minutes past midnight in his own hospital on his own floor with a patient he had been excluded from, the limit had been reached. He walked in without looking at the military personnel, which was itself a studied choice, the performance of not noticing as assertion of territorial claim. "I want to see the chart," he said. Kren was not in the room. She had stepped out 40 minutes ago and had not returned, which meant she was managing the secondary situation. The man with the fake ID, the intelligence implications, the facility security review that was apparently already underway on the floors below. Strickland was in the room but was on a call in the corner. Lena looked at Harlan. "The chart is a federal jurisdiction record. I can give you a clinical summary. I am the chief of surgery in this hospital." "I know." She kept her voice even, not accommodating, even. "The patient's saturation is 94 and holding. Blood pressure is trending down from the peak. We administered a 2-component pharmaceutical intervention approximately 45 minutes ago, and it's producing the expected response." She paused. "He's going to make it through the night." Harlan absorbed this. His face went through something she recognized. Not the recalibration of authority this time, not the reassertion of hierarchy. Something more personal, less practiced. He looked at Warren in the bed, at the monitors, at the configuration of equipment in a room that he had walked into 4 months ago as chief of surgery and had never thought about twice, and his face held the specific difficulty of a person confronting a situation that does not align with the framework they have built for understanding their own competence. "How did you know?" he said. "This morning, Vosburg." She considered the question. It was asked without the armoring of authority, asked, she thought, by a person rather than a position. The skin changes were consistent with compartment syndrome developing. The directional spread over 48 hours was atypical for standard post-surgical inflammation. She paused. "And I've seen it before." "Where?" "A beat." "Not in a hospital." He looked at her for a moment. Something in his posture changed, not dramatically, not the visible collapse of pride that makes a satisfying story, but the smaller and more real version of it, the incremental reduction of a man who is in the process of updating an assumption that has cost something. "The scope review," he said. "You can continue it if you want to," she said. "That's your administrative right." "I initiated it because—" He stopped. Started again. "The meeting this morning. What I said about nursing staff. It was policy, not personal." "I know." "But it affected someone who had just—" He stopped again. "Who had just caught something that mattered," she said. "Yes." He looked at the floor, then at Warren, then at her. "I'll suspend the review." She nodded. Once. The way she had nodded in the administrative conference room 7 hours ago, with the same economy and none of the same weight behind it. "Thank you." He left. Strickland lowered her phone and looked at Lena across the room with an expression that was not quite readable and was not trying to be. "That was gracious of you." "He's a good surgeon," Lena said. "He's not a good manager of other people. Those are 2 different problems. Most institutions treat them as the same qualification. Most institutions are wrong about that." Strickland looked at her for a moment. Then she almost smiled, and then she put the phone back to her ear. The secondary situation resolved in pieces over the next 2 hours, the information arriving in layers the way it always does when an investigation is catching up to an event rather than anticipating it. The man with the fake ID was identified through biometric processing as a former contractor with a defense analytics firm that had held federal facility access clearances that had been revoked 14 months ago, which placed the revocation at an interesting moment in a timeline that Lena was not privy to, but could observe the shape of through what was being said in the room around her. Delgado returned from wherever he had taken the man and had a 15-minute conversation with Kren near the window that involved a map displayed on Delgado's tablet and several location references that Lena deliberately did not try to retain, because the information that belonged to her portion of this situation was the medical information, and the rest was not hers to carry. At 2:15 in the morning, the report came through that the two other individuals from the Asheville property, both now in different medical facilities, were stable. The compound identification from Hargrove Central's specialized talk screen had been transmitted to both facilities within 20 minutes of the results, which meant the treatment protocol had been implementable before either of them reached the critical window. One of them had required a more aggressive intervention than Warren's, based on differences in body weight and pre-existing vascular conditions. Both were alive. Lena received this information from Strickland and wrote it in the chart and did not say anything for a moment. "You saved 3 lives tonight," Strickland said. "We stabilized 3 patients," Lena said. "The treatment recovery is going to take weeks." "That's not what I said." Lena looked at the monitor. 95, 135 over 81. "I know what you said." She allowed herself to feel it for approximately the same 4 seconds she'd allowed herself to feel the activation message in the elevator, and then she put it somewhere accessible and returned to the chart. At 3 in the morning, Kren returned to 4J with a woman Lena had not seen before. 50s, civilian dress, the specific quality of authority that comes not from rank insignia, but from the particular way rooms rearrange their attention when you enter them. She introduced herself as Deputy Director Haas without further elaboration, and the absence of further elaboration was itself elaboration. Haas looked at the patient for a long moment. Warren had been drifting in and out of a light sleep for the last hour, which was the body doing the correct thing, conserving resources, initiating repair. His vitals in sleep were marginally better than his vitals awake, which was also correct. Haas looked at Lena. "I've been given a full briefing on the last 12 hours, she said, "including the sequence of events before the patient arrived, the scope review, the floor transfer." "That's an internal hospital matter," Lena said. "It's already being addressed." "I'm aware." Haas's expression did not telegraph what she thought about any of it. "I want to ask you something directly. The compound identification, the interpretation of the environmental panel ratios, that's not in any standard nursing training curriculum." "No." "And the intervention protocol for a synthetic vasoconstrictor with modified pharmaceutical markers, that's not in a standard nursing curriculum either." "No." "Where's it from?" Lena looked at her evenly. "The same place the rest of it is from." Haas absorbed this. "Your dormant liaison status has been flagged for formal review. That's not a threat. It's a process that was going to happen when the status was reactivated regardless of circumstance." She paused. "Given the circumstances, the review is likely to go in a particular direction." Lena said nothing. "I'm telling you this because you should know, not because it requires a response from you right now." Haas looked at Warren, sleeping. "He trusts you. He told me that directly when I spoke with him 40 minutes ago. He barely knows me." "People in his position develop accurate reads quickly," Haas said. "It's the job." She left with the same absence of ceremony with which she'd arrived. Lena stood in the room that had been dark and empty at the beginning of this shift and was now full of equipment she'd placed and people she'd met, and a patient who was asleep with oxygen saturation numbers that were doing what she needed them to do. And she thought for a moment about the note she'd folded into her scrubs pocket that morning, the medication observation, the one that had started the whole chain that had led to Vosberg's diagnosis, and the scope review, and the transfer order, and the elevator, and the activation message, and everything that followed. She had folded that note because something in the numbers hadn't sat right. That was all. No training had told her to do it. No protocol had required it. Something in the numbers hadn't sat right, and she was constitutionally unable to let that go. She pulled the original note from her pocket. She had never removed it, and looked at it. Then she filed it in the patient chart under nursing observation, pre-admission, which was technically the wrong category but was the honest one. She put the chart down and checked Mrs. Tarkington's room status on the floor monitor, because Mrs. Tarkington was still on this floor and still had a daughter named Britt who called at 7 and still deserved someone who remembered that. The monitor showed stable vitals and a note from the evening nurse that the respiratory rate had improved. Lena added a 2-line follow-up note for the morning shift. Then she sat in the chair beside Warren's bed and checked his trace one more time and allowed herself, carefully, to be tired. At 4:40 in the morning, the door opened for what felt like the 40th time, and Gary Platt appeared in it looking like a man who had been awake for longer than he should have been and had recently received news that had rearranged several of his operating assumptions. He looked at the room, at the equipment, at the sleeping patient, at Lena in the chair. "The security team downstairs," he said. "They're saying the man they detained had building access credentials that were issued through our administrative system." She looked at him. "Issued how?" "That's what they're working out." He came further into the room, which was not quite comfortable for him. She could see it in how he moved, the specific discomfort of a familiar space that had become unfamiliar. "Someone inside this building issued a temporary credential to a person who doesn't work here. The date error suggests it was done quickly. Either the person who issued it was careless or they expected it not to be examined closely," Lena said. "Yes." He was quiet for a moment. "I've been facilities manager here for 11 years. Nothing like this has happened." "I know. I need you to know that I didn't—" He stopped. "The scope review. I was in that meeting. I didn't push back." "No," she said. "You didn't." He absorbed that. "I should have." She looked at him with the direct and unsentimental honesty that was the only version of this kind of conversation she knew how to have. "Yes, you should have." He nodded once, with the quality of someone accepting something that deserved to be accepted without negotiation. "The credential issuance is going to have to be traced through the administrative access logs," she said. "Whoever issued it had system access. That narrows the field considerably." "I know. The security team is already on it." He looked at Warren again. "Is he going to be all right?" "He's moving in the right direction." Platt left. Lena sat with the quiet for approximately 3 minutes, which was the longest uninterrupted quiet she'd had since 7:15 that morning, when Harlan had stood at the head of the conference table and told the floor that nurses should stay in their lane. She thought about lanes, she thought about systems and hierarchies, and the very specific way in which structures designed to ensure quality could become structures that ensured the appearance of quality, which was a different and considerably more dangerous thing. She thought about Mr. Vosberg's wife sitting in that room for 2 days, watching something get slowly wrong with her husband's leg, and not being taken seriously because the people with the authority to act had already decided what was happening and had no framework for the revision. She was still thinking about this when Strickland came back in at 4:53 with a face that had moved from operational focus to something that carried the weight of new information, the specific compression around the eyes and jaw of a person who has received news that is not a surprise but is still difficult. "The credential trace is back," Strickland said. Lena waited. "The temporary badge was issued from the administrative system at 14:17 this afternoon." A pause. "The account that issued it belongs to Dr. Victor Harlan." The room held very still. Lena looked at Strickland, at the monitor, at the sleeping patient, at Strickland again. 14:17, she said. "That was 40 minutes after the scope review meeting." "Yes." She said nothing for a moment because the shape of what had just been said required a moment to fully form. Harlan had initiated the scope review in the morning. Harlan had pushed her off the floor in the afternoon. At 14:17, 40 minutes after the scope review, someone using Harlan's administrative account had issued a temporary credential to a man who was now in federal custody for accessing a secure patient room during a national-level medical event. "He was here," she said, 2 hours ago. "He came into this room." "I know." He apologized. He offered to suspend the scope review. She was not saying this with emotion. She was saying it as information, running the timeline the way you run a timeline when a piece of information has just changed what every prior piece means. "He came in here to see what we had." Strickland's face was not the face of someone who had not considered this possibility. "We don't know yet whether the credential issuance was Harlan directly or whether his account was used without his knowledge. The investigation will determine that." "But you're treating it as the former." A beat. "Yes." She looked at the door through which Harlan had walked 2 hours ago, where he had stood and asked her where she had learned to read compartment syndrome, where he had said he would suspend the review, where he had seemed like a man who was updating an assumption. She had assessed that performance as honest. She had been, in some part, persuaded by it. She filed that away. The error, the persuasion, the cost of extending good faith in the wrong direction, not as self-punishment, but as data. You learned from what you got wrong the same way you learned from what you got right, and the learning only worked if you were honest about which was which. What happens now? She asked. His building access is suspended pending investigation. He won't be notified until the security team is in position. Strickland met her eyes directly. That happens in approximately 30 minutes. Lena looked at the monitor. Warren's oxygen saturation was 96. His blood pressure was 132/79. She looked at the clock. 4:56 in the morning. In 30 minutes, the man who had told her she was just a nurse would be escorted from the building by federal security personnel in his own hospital, on the floor where he had stood that morning, and explained to a room full of people why systems required structure, and structure required everyone to understand their position. She found that she did not feel satisfaction about this, exactly. She felt the specific flatness of a situation that had resolved in the way it needed to resolve, which was not the same thing and did not feel the same in the body. She turned back to the bedside. Warren's eyes were open. He had been awake for some portion of the last few minutes. She didn't know how long, and he was looking at her with the direct and measured attention she had come to recognize as his natural register. She looked back at him. "How do you feel?" He thought about it. Then he held up 3 fingers, then 2. Then, slowly, 1. 1. She looked at the number for a moment. Then she looked at the chart and wrote it down and added a note about the cognitive revision process, the same as before, because the revision was still there and it still mattered. "Good," she said. She reached over to adjust the flow rate. A small adjustment, 0.5 millimeter on the valve, the kind of change that looked like nothing and made the difference it made. And her hand was on the equipment when she heard, from somewhere down the corridor outside 4J, a voice she recognized. Harlan's voice. Not in the room, in the corridor, elevated. The specific elevated register of a man who has been told something he was not expecting to be told and is responding to it in the way that men who have held authority for a long time sometimes respond, loudly, in a location where the loudness is visible, as though volume is a form of leverage. Then other voices. Controlled. Official. The voices of people who do not need to match the volume because the volume is not actually the variable that matters. Then the sound of footsteps. Multiple. Moving away from 4J toward the elevator. Then quiet. She took her hand off the equipment. Warren was still watching her. She met his eyes. He said nothing, and she said nothing, and the monitor between them showed numbers that were going in the right direction, and the corridor outside was quiet, and somewhere in the hospital a situation was being concluded that had begun long before she'd ever folded a medication note into her pocket. Or maybe it had begun exactly there. She wasn't sure the two things were separable. Then Strickland's phone buzzed. Strickland read the message and looked up. "He's out of the building," she said. Lena nodded. "There's something else," Strickland said. Her voice had shifted. Not the operational focus, not the brisk authority. Something more careful. The investigation team pulled Harlan's full administrative access history. The credential issued today wasn't the first one. Lena looked at her. There have been 8 temporary credentials issued from his account in the last 4 months. 6 of them to individuals who have now been flagged in connection with the defense contractor whose access was revoked 14 months ago. Strickland held the phone so Lena could see the summary on the screen. The facility agreement that covers the isolation suite, the access protocols for 4J, the emergency admission procedures for federal patients. She paused. He had all of it. All of the documentation. He's been here for 3 months. 3 months. 3 months was not long enough to build a network. It was long enough to be placed in a position by one. He didn't apply for this job, Lena said. It was not a question. The shape of it was already there. He was recruited, Strickland said. We think the position was specifically targeted. The previous chief of surgery left under circumstances that... She stopped. That's being reviewed now. Lena looked at the floor, at the chart, at Warren. He knew I was the liaison, she said. He targeted me specifically this morning because he knew who I was, and he needed me off this floor before the patient arrived. That's the working hypothesis. She sat with that for a moment. The morning meeting. The policy language about scope and systems. The smooth, prepared delivery of it. Not the improvised reaction of a surgeon confronting a challenging nurse, but something planned. Something that had been ready before she'd ever said a word about Vosberg's leg. She thought about the scope review meeting and felt retroactively cold, the specific cold of realizing that a situation you lived through had been more dangerous than it appeared at the time. The scope review documentation, she said. Is it still in the system? Suspended, as he said it would be. Before or after security was alerted? Strickland looked at the phone again. Something crossed her face. After. Which meant he had suspended it when he came into the room, 2 hours ago, knowing what he was doing, using the gesture as cover. The apology. The question about where she had learned to read the signs. All of it calibrated, all of it performed, and she had read it as honest because she had been exhausted and it had looked like what honesty looked like. She had extended good faith in the wrong direction. The error was real, and she was going to sit with it. But she was sitting with it on the right side of a situation that could have ended very differently, and Warren's saturation was 96, and somewhere in 2 other hospitals, 2 other people were alive and stable, and the man with the wrong date on his ID badge was in federal custody, and Harlan was out of the building. She picked up the chart. She was writing when Kren came back into the room at 5:22 with an expression that was the most unguarded she'd seen on the general's face since she'd arrived. Not unprofessional, not exposed, but something close to relief and not bothering to conceal it. The full compound analysis from all 3 patients has been compiled and transmitted to the investigation team, Kren said. Trace sourcing on the modified vasoconstrictor is pointing toward a specific synthesis facility that's been under a separate investigation for 11 months, she paused. Tonight connected 2 investigations that had been running parallel without a linking event. The linking event being that someone tried to kill 3 federal officials and failed, Lena said. Yes. Kren looked at Warren. I was asleep again. Because of the person in this room. Lena set down the pen. She looked at the window, the narrow one above the monitor bank, east-facing, and the sky beyond it had moved from the absolute dark of 3 in the morning to the specific dark blue that happens approximately an hour before light arrives. Not dawn. The preparation for dawn. The thing that comes before the thing. She turned back to the chart. There was still a full shift ahead. Mrs. Tarkington's morning assessment. The 3 other patients on the floor, whose care had continued through this night, with the evening staff covering and who would need a proper handoff. Warren's 6-hour vitals review, which was coming up at 6:15, and which she intended to be present for regardless of what anyone's administrative record said about her assigned floor. She picked up the pen again. And somewhere in the building, in the administrative level, a folder had been opened. A personnel file with a name on it and 7 hours of documented clinical events that no scope review was going to survive. And a record that began with the words asset activation and ended with 3 patients, stable and contained in between it. Everything she had done in this room tonight, all of it cataloged in the careful, precise language of someone who had learned a long time ago that the record was the thing that lasted. The chart was almost complete. She had 2 more lines to write. She wrote the last 2 lines and closed the chart at 5:29 in the morning. The room was quiet in the specific way that rooms go quiet after long, sustained emergency. Not peaceful, not restored, but emptied of the acute pressure that had filled every cubic inch of it for the past several hours. The equipment still beeped its rhythmic argument. The monitors still ran their traces. But the quality of attention in the room had shifted from the razor-edge vigilance of active crisis management to the steadier, more sustainable vigilance of someone watching a situation that has turned a corner and now needs time more than intervention. Warren was asleep. His saturation was 96 and had been for 40 minutes without fluctuation. His blood pressure was 131/77, which was the best number she'd seen from him since admission. His face in sleep looked older than it had looked awake, the specific unguarded age of a person whose defenses have finally come down because the body has overridden the habit of alertness. She had seen that look before, on people who had been through things, and it always struck her as the most honest version of a face. She sat with him for a few minutes, not because it was clinically necessary, but because someone should be sitting with him, and the night staff had their hands full, and she was here. This was not in any protocol. It was simply the thing that needed doing. At 5:45, she left 4J and walked the corridor to the nursing station, where the overnight nurse, a woman named Tara Shields, who had been running the floor competently through all of it without ever being briefed on what exactly was happening in the isolation suite, looked up with the expression of someone who has had a very strange night and is not entirely certain how to categorize it. "How's your patient?" Tara asked. "Better," Lena said. "He needs a 6:15 vitals check, and I want a comparison to the baseline from midnight. Can you flag me when you do it?" "You're not going home?" Lena looked at the window at the end of the corridor, still dark blue, still the preparation for something rather than the thing itself. "Not yet." She went to the broom, which was empty at this hour, and poured coffee from a pot that had been sitting long enough that it tasted like a decision more than a beverage. And she stood at the small window that looked out over the hospital parking structure and drank it anyway because the caffeine didn't care about the taste. She thought about Harlan. Not with anger. Anger was too simple, too clean for what she actually felt, which was something more like the complicated residue of a situation that had been both personal and structural and had never been entirely separable into its parts. He had walked into this hospital 3 months ago, placed there by people who had done their homework, who had identified the facility's federal agreement and the dormant liaison status and the access protocols for 4J, and had built a mechanism around all of it. Harlan himself was either a committed participant or a recruited tool, and the investigation would determine which. But the investigation's answer to that question didn't change what his actions had cost in the hours before the patient arrived, what they had cost Mr. Vosberg, what they had almost cost 3 people who were now alive and stable in 3 different facilities. There was a version of this where she didn't fold the medication note into her pocket, where she went home, ate a full sandwich, came back in the morning, and did what she was told. Where the scope review went through and she was on the step-down unit on 3 when the convoy arrived and someone else had walked into 4J and found equipment that wasn't ready and made assessments that were reasonable and insufficient. She didn't spend long in that version. It wasn't useful. But she didn't pretend it wasn't there either, because the not pretending was part of how she stayed honest with herself about what had actually happened and what it had cost and what it had mattered. She finished the coffee and rinsed the cup and went back to the floor. The 6:15 vitals check showed Warren at 97 saturation, 129/76, heart rate 62. Lena stood at the monitor and looked at the numbers and felt something settle in her chest that had been braced for most of the night. She wrote the numbers in the chart. She wrote a clinical assessment note that was 4 sentences long and said what it needed to say without decoration. She flagged it for the incoming day shift physician and added a secondary flag for Colonel Strickland, who was somewhere in the building doing things that were not Lena's portion of this situation. At 6:40, she went to check on Mrs. Tarkington, who was awake and sitting up in bed with the alert and somewhat combative energy of a woman whose body had remembered how to breathe and whose mind had spent a night reconsidering several things. "You're still here," Mrs. Tarkington said. "I am." "You were here yesterday morning, too." "Yes." Mrs. Tarkington looked at her with the direct assessment of a woman who had spent enough years reading people to do it without ceremony. "Something happened last night. The floor was different. People were moving differently." "There was a complex admission," Lena said. "It's been managed. You look like you've been awake all night." "I have been." "And you're still here checking on me." "Your daughter calls at 7, Lena said. "I wanted to make sure you were ready for it." Mrs. Tarkington's face did something complicated and genuine, the kind of expression that arrives when someone has said the right thing in a situation where you weren't expecting the right thing. She looked at the window. "She worries," she said. "I know. That's what she's for." It was the wrong thing to say technically, too personal, not the appropriate clinical register. Mrs. Tarkington laughed, a short sound, real, the first time Lena had heard her laugh in 2 days. The laughter made her O2 numbers go up a point, which was not in any study Lena knew of, but which was the kind of thing she kept track of anyway. She left Mrs. Tarkington's room at 6:53 and stood in the corridor for a moment with nowhere specific to be for the first time in approximately 22 hours. The day shift was beginning its arrival, the specific gradual population of the floor with a new team that brought with it a different energy, the energy of people who had slept, who had not been in it, who were picking up the threads of something they were going to need the night shift to explain. Lena watched them file in and thought about the explanation, about how much of the last 14 hours could be conveyed through normal shift change channels, which was approximately 30% of it. The other 70% was going to live in a classified record and in the bodies of 3 people who had a long recovery ahead of them, and in the specific memory of a corridor on the 4th floor of Hargrove Central, where a man with a fake ID had stood and looked at a talk screen and understood that he had been too late. Donna Reeves arrived at 7:03, which was 3 minutes later than usual, and stopped in the corridor when she saw Lena. "You're still here." "People keep saying that." Donna looked at her with the accumulated weight of someone who had witnessed the previous day and had spent the night absorbing it. "Is he—" "The patient in 4J? Stable, improving." Donna let out a breath that carried a lot in it. "Harlan," she said, and then stopped, because the single word contained enough. "The investigation will handle it," Lena said. "Gary said federal security walked him out at around 5 in the morning." Donna looked at the floor. "I was on this floor when he came in 3 months ago. I thought he was a difficult surgeon, the usual kind of difficult." "So did I," Lena said. "This morning." "You figured it out, though." "The investigation figured it out. I just identified a gap in the picture." Donna looked at her with the expression of someone who recognizes understatement and has decided not to argue with it. "The step-down transfer, the scope review." "Already being suspended," Lena said, "before the rest of it came out." "It shouldn't have happened in the first place." "No," Lena said, "it shouldn't." They stood in the corridor together for a moment with the specific comfortable weight of 2 people who have been in the same building through the same long night and don't need to perform anything for each other. "Go home," Donna said. "I will." She didn't leave immediately. She went back to the nursing station and completed her shift documentation. All of it. Every patient she had touched in the previous 22 hours. Charted in full with the care that she brought to everything she wrote down. Because the documentation was part of the care, and the care did not stop at the edge of what would be noticed or evaluated. She was finishing when Briggs appeared at the station, looking considerably more functional than he had at 2 in the morning, which meant he had actually eaten something and possibly slept for an hour in the break room. He was in full uniform, which was different from the fatigues he'd worn during transport. "Heading out," he said. "Good work last night," she told him. "Your log was complete. Your intervention decisions during transport were sound." He looked slightly startled by the directness of it, not the compliment itself but the specificity, the fact that she had named what he had done correctly rather than offering general positive regard. "I wasn't sure about the dexamethasone timing," he said. "You made a reasonable call with the information you had. In the field, that's what you have." She met his eyes. "Write it up exactly as it happened. The uncertainty too, not just the decisions. Those reports get read by people who need to know what actually occurs, not what should have occurred." He nodded with the seriousness of someone filing this away in a location where it would stay. "Yes, ma'am." He left. She watched him go with the particular feeling of someone who has briefly intersected with a young person who is going to be very good at something that matters, and who will not remember where that certainty originated but will carry it anyway. Well, at 8:15, Kren found her in the corridor outside 4J. The general had changed into fresh dress uniform at some point in the last few hours, which communicated that she had been somewhere other than Hargrove Central, or that she had logistics Lena was not aware of, which was the more likely explanation. "Walk with me," Kren said. They walked toward the end of the corridor, away from the nursing station, into the quieter reach of the floor near the east windows where the morning light was now fully established, the pale specific light of a North Carolina morning in early fall that hit the linoleum floors at an angle and made the whole corridor look, briefly, like somewhere other than a hospital. "The investigation is moving quickly," Kren said. "Faster than these things usually move. The synthesis facility connection gave them a thread that had been inaccessible before." She paused. "Harlan is in federal custody. Not local, federal. That's the level at which this is being handled. And the network he was connected to? Being rolled up. It'll take time. The immediate threat to the patient has been addressed, and the associated individuals have been identified and are either in custody or under surveillance." She looked at the window. "The 2 others from Asheville are both improving. The more critical one was discharged from emergency care this morning. The compound identification you produced made the treatment replicable. Lena absorbed this. 3 people. 3 facilities. 1 compound identification produced in a room that hadn't been operational 4 hours before the patient arrived. Your dormant liaison status, Kren said. The review I mentioned. Yes. It has been completed. She looked at the general. That was fast. The circumstances accelerated it. Kren's voice had the careful precision of someone delivering information that has weight and wants it to land accurately rather than dramatically. The review concluded that the dormant status should be formally reclassified, not reactivated, reclassified. To what? Active reserve, with the specific designation of embedded civilian medical specialist. A pause. Which is a classification that has existed in the protocol architecture for approximately 12 years and has been assigned 3 times. You would be the 4th. Lena looked at the morning light on the linoleum. She thought about the activation message on the encrypted phone, 14 months of silence and 1 line of text, and about what it meant that the review had concluded in one direction rather than another after a night in which she had spent 6 hours managing a classified federal medical emergency using training she had technically set aside. What does that mean practically? She asked. It means that when situations like last night occur, the activation process is formalized. You would be briefed in advance of events that may require your involvement rather than receiving an activation message with 12 minutes to prepare. Kren looked at her directly. It also means that your civilian position here, if you choose to remain in it, carries a formal security architecture that prevents what happened yesterday from being used against you operationally again. It was a careful way of saying that a chief of surgery installed by a hostile network would not be able to push her off the floor 40 minutes before a federal patient arrived. And if I don't choose to remain in it? Lena asked. There are other options, Kren said it without pressure. The review identified several positions that would benefit from your specific combination of skills. None of them require a decision today. I don't need other positions, Lena said. Kren waited. I need this one, Lena said. Mrs. Tarkington is on this floor, and her daughter calls at 7, and she's going to need a week of careful respiratory monitoring before she can go home. Mr. Vosberg had a fasciotomy last night, and he's going to have a recovery that requires consistent nursing management. There are 11 other patients on this floor who have been managed through the most disrupted night in this unit's recent history by a skeleton staff who did a good job and are going to need support through the handoff. She paused. The work is here. I'm not going somewhere else to do different work when there's this work. Kren looked at her for a moment. Then she said something that Lena did not entirely expect from a brigadier general who had been awake for most of the same night. That's the right answer. She said it quietly, without ceremony, and it landed differently than it would have landed with ceremony. It landed like a thing that was simply true and was being acknowledged as such. The reclassification is in process, Kren said. You'll receive formal documentation within 48 hours. She paused. And Marsh, the scope review documentation, it's been pulled from the system entirely, not suspended, removed. The basis for it has been determined to be procedurally invalid, given the circumstances of its origin. By who? By the hospital's CMO, who has been fully briefed, and by the investigative authority overseeing the Harlan matter, who determined that the review was initiated as an operational action rather than a clinical one. Kren's voice was precise on this. It will not appear in your employment record. Not the initiation, not the transfer order, not any of it. Lena looked at the window, at the morning, at the floor. She had been in that administrative conference room less than 15 hours ago, sitting across from Patricia Wool, nodding once with the weight of someone accepting something that deserved to be accepted without argument. She had walked to the elevator and pressed the button for the lobby and told herself that the work was the work regardless of which floor she was assigned to. The work was the work. That had been true then, and it was true now, and the official record catching up to the reality of it did not change what the reality had been. But it mattered. She was honest enough to admit that it mattered. Not for pride or not only for pride, but because the documentation was part of the care, and the care included the accurate record of who had done it and why. Thank you, she said. She meant it without performance, which was the only way she knew how to mean things. Patricia Wool found her at 9 in the morning. The nursing director looked like a woman who had processed a significant amount of information in a compressed period and had arrived at the conclusion that some of it required her to be in a corridor having a conversation she would have preferred not to need to have. She stopped in front of Lena with the direct manner of someone who has decided that the cleanest path through a difficult thing is the most direct one. "I owe you an apology," she said. Lena waited. "The transfer order, the scope review. I acted on Dr. Harlan's assessment without adequate independent verification of the situation." She said it with the flat honesty of someone reading from an internal accounting. "I've been doing this work for 16 years and I know better than to process a nursing scope review in 40 minutes based on one physician's complaint, and I did it anyway, and a patient could have—" She stopped. "Mr. Vosberg could have deteriorated significantly during that window." "He didn't," Lena said, "because you didn't stop after I told you to step back." Wall looked at her. "That's not a criticism. I'm aware of what it cost you to keep going in that environment. It cost me less than stepping back would have cost him." Wall absorbed this. "The board has been briefed on the full situation. The CMO has requested a formal review of the clinical hierarchy protocols on this floor, specifically regarding the process by which nursing concerns are escalated when the attending physician is not responsive." She paused. "It's going to take time. These reviews always take longer than they should." "I know. But it's happening." Wall looked at the corridor, at the morning activity of the day shift, at the floor she managed. "I'm going to need someone to be involved in designing the new escalation protocol. Someone who understands what it looks like from the nursing side when the current system fails." Lena looked at her. "I'm asking you," Wall said. Lena considered it. Not the decision itself. The decision was immediate and clear, but the proper acknowledgement of what was being offered, which was not a consolation prize and not a political gesture. It was actual work that needed doing by someone who understood the specific failure point that had nearly cost a patient his leg and had contributed to the conditions in which a hostile operative could use a scope review as a weapon. "Yes," she said. Wall nodded. Once, with the quality of someone who has said what needed to be said and received the answer it warranted. "Get some sleep first." "I will." Wall left. What? She did not immediately go home. She went to check on Warren one more time because she was constitutionally unable to leave without checking, and found him awake and attempting, with considerable effort and visible frustration, to write something on a small notepad that one of the overnight staff had left on his tray table. She stood in the doorway of 4J and watched him for a moment. The effort was real. His hand moved with the careful, deliberate pressure of someone compensating for fine motor disruption, forming letters that required more concentration than they should have. He had been a man accustomed to moving through the world with fluency in every register, and the neurological disruption had stolen a specific piece of that fluency, and he was fighting to reconstruct it in the only way available to him right now, which was slow and imperfect and determined. She came in and stood at the bedside and looked at what he had written. It said, "Thank you," in letters that were uneven and slightly large and entirely legible. She looked at it for a moment. Then she looked at him. He looked back with the directness that was his baseline and with something underneath it that was personal and not performed and not leveraged, the simple human thing of a person who has been kept alive through a night they were not supposed to survive and knows who was in the room. "You're going to have a full recovery," she said. "The vascular component will take the longest. 3 to 4 weeks, probably. The speech will come back faster than that." She paused. "The team that takes over your care when you're transferred will have the full treatment record. I've documented everything." He nodded. Then he picked up the pen and wrote something else on the pad, slower, with more effort. He turned it to face her. "Who are you really?" Not a question mark. He was asking it as a statement of curiosity rather than a challenge, which told her something about how he thought. She looked at the notepad, at the question that wasn't a question, at the man who had survived the night because she had stayed in a building she had been told to leave, had rebuilt a room that had been dark, had read a compound ratio in an environmental panel that was designed to look like nothing. "I'm the nurse on 4, she said. He looked at her for a long moment. Then the ghost of the smile appeared again, the same ghost she'd seen in the middle of the night, the dark appreciation of someone who recognized an answer that was both completely true and not the whole truth. She folded the notepad closed, gently, and left it on the tray table. She straightened the monitor cable that had been slightly displaced, a small thing requiring 30 seconds and no clinical significance. And she did it anyway because it needed doing, and she was there. Then she said goodbye, and she left. The drive home took 19 minutes. She did not listen to anything in the car. She drove with the windows cracked and the fall air moving through and her hands on the wheel at a grip pressure she was aware of and consciously reduced twice, because the hands take a long time to catch up to the fact that the acute phase is over. She thought about what Wall had said, about the escalation protocol review, about what it would actually take to build a system in which the next nurse with a correct observation and an unresponsive attending didn't have to choose between the patient and the consequences. The answer was not simple. Systems were not made simple by the desire for them to be. They were made better by the slow incremental work of people who had been in the failure point and understood it from the inside, who were willing to sit in rooms with administrators and explain, specifically, what it felt like to hold a correct piece of clinical information and have no pathway that didn't require you to absorb a cost to use it. She had been in enough briefing rooms in enough context to know that the person who described the failure from the inside was never comfortable in that room and was always necessary in it. She had never chosen comfortable over necessary. She was not going to start. She pulled into her parking space and sat for a moment with the engine off. The morning was full on now, the particular fall light that North Carolina did with a specific quality, warm without heat, clear without the flat clarity of summer, the light that made ordinary things look slightly more precise than they were. Her building, the tree in front of it, the parking lot. She had driven this parking lot into and out of for 4 years, every shift, and it had never looked specifically like anything. This morning it looked like the place where she arrived after a night that had mattered. That was not nothing. She slept for 6 hours. Not well. She rarely slept well after acute cases, not because of bad dreams, but because the cognitive process that had been running at full capacity for a sustained period did not simply stop when the situation resolved. It wound down in its own time and at its own pace, and the winding down involved a kind of vivid background processing that was not quite sleep and not quite waking. She thought, in that space, about the morning meeting, Harlan, at the head of the table, organized and prepared, explaining that nursing staff should understand their position in the system. She thought about how persuasive clarity is, how a person who explains a wrong thing with enough structure and confidence can produce, in most rooms, the appearance of correctness. She thought about the note in her pocket, the small folded piece of paper with the medication observation that had started everything, that had cost her the floor transfer and the scope review and the explicit public statement that she was operating outside her designated scope. She had been right. The scope designation had been wrong. These were not the same argument, and that was the thing that mattered. The distinction between what you are permitted to see and what you can see, between what a hierarchy decides your competence covers and what your competence actually covers. Harlan had arrived at Hargrove Central with the explicit operational goal of ensuring that the one person on that floor who could identify what was happening to Warren would not be in a position to do so. He had done it through administrative mechanism, through the language of systems and protocols and professional scope. He had understood that the most efficient way to neutralize a capable person was not to confront their capability directly. It was to construct a framework in which the capability could not be expressed without consequences. She thought about every nurse who had ever held a correct observation and set it down because the cost was not survivable. Every time the framework had worked as intended, not to protect patients, but to protect the hierarchy from the challenge of being corrected. She would not let herself be sentimental about this. Sentimentality was not useful. But she was going to sit in the protocol review room and she was going to describe the failure point precisely and without softening it, and she was going to do it for every person who had ever stood in a corridor with the right information and nowhere safe to put it. She woke at 3 in the afternoon. She made coffee that was better than the break room version, ate something that qualified as a meal, and sat at her kitchen table for a few minutes with the specific quiet of a person who has completed something and is in the brief space before the next thing begins. Her personal phone had several messages. Donna. Tarkington's daughter came, she cried. In a good way. A message from Patel. Vosburg post-surgical is clean. He asked who caught it. I told him. He wants to say thank you. A message from Tara, the overnight nurse. Whatever you did with the equipment in 4J before the military patient arrived, the pre-use check log is the most complete one I've ever seen. just so you know." She read each message. She did not respond immediately because the responses deserved more than the quick tap of a tired thumb, and she was going to write them properly when she had the right words. The encrypted phone had one message, received at 11:47 that morning. Formal documentation incoming 48 hours. Active reserve reclassification confirmed. Well done, Marsh. No sender name, no preamble. The same economy as the activation message, the same flat professional language, the same absence of performance. She read it and set the phone down and looked out her kitchen window at the afternoon that was getting on with itself outside. Well done. She thought about the word done and its relationship to the word finished and the way they were not the same thing. What was done last night was the acute phase, the crisis, the identification, the intervention, the managed resolution. What was finished was something else, a version of her professional life in which she moved through a hospital floor with her past folded away and her expertise expressed within designated limits, and the whole of what she had been and done kept in a separate compartment from the work she was doing now. That version was not coming back. The formal reclassification would make it official, but the reality of it had been established in the corridor of Hargrove Central at the moment. She turned around from the lobby exit and walked back toward the elevator. It had been established in 4J when Strickland had said, "Where is it from?" and she had said the same place the rest of it is from. It had been established most precisely in the moment when Kren had asked her if she wanted a different position, and she had said the work is here, the work was here, she was here. Both of those things now, in the same place, without apology and without concealment. Awesome. She was back on the floor at 6 the next morning. Not because anyone had called her in, not because of the reclassification or the protocol review or any formal request. She came back because the morning shift started at 6:30 and she wanted to be there for the handoff. She came in through the main entrance and rode the elevator to 4 and walked to the nursing station where Donna was already at the desk, coffee in hand, with the expression of someone who had also arrived early without specifically being required to. Donna looked at her. "You slept." "Some." "Vosberg is asking for you. His wife is here." "I'll go in a few minutes." She put her bag under the station counter. "Tarkington's morning respiratory check. Already on the schedule. I put you on it specifically." Donna looked at her with the direct warmth of someone who has known you through something and is not going to make a speech about it. "The new escalation protocol review meeting is next Tuesday. We'll put your name on the agenda." "I know." "You're listed as clinical consultant." Donna paused. "Not participating nurse. Consultant." Lena looked at the morning floor, the corridors filling gradually with the day's first light and the day's first motion, the specific choreography of a hospital unit beginning its cycle. The sounds she had been hearing for 4 years, monitors, footsteps, the PA system's flat authority, somewhere near the end of the floor, a cart being moved with a wheel that needed replacing, the same wheel, the same sound, that she had been meaning to report for 3 weeks. She picked up a maintenance request form from the station supply shelf, filled it out, put it in the correct bin. Small things. Correct things. The work that looked like nothing and was everything. "I'll go see Vosberg," she said. She walked down the corridor toward 4C and the morning gathered itself around her with the indifferent efficiency of mornings everywhere, carrying everything forward without concern for what had happened the night before, which was the correct behavior of mornings and one of the things she had always respected about them. She pushed open the door of 4C. Mr. Vosberg was sitting up. His wife was in the chair beside him, her hand on his. He looked better than he had 2 days ago. The particular improved quality of a person whose body has been through a significant corrective event and is now, slowly, responding to the right treatment. The leg was elevated. His face was still carrying pain, but the panic that had been in it, the specific panic of someone whose body was doing something wrong and no one was acknowledging it, was gone. His wife stood up when Lena came in. She was a small woman in her 60s with the composed expression of someone who had spent 2 days being calm for her husband and had a lot to release but was choosing the timing of it carefully. She crossed the room and put both of her hands on Lena's arm and said simply, "Thank you." Lena covered the woman's hands with one of hers for a moment. Then she stepped back and looked at the patient. "How's the pain?" 6, Vosberg said. "Maybe 5.5. That's honest. The post-surgical inflammation is going to sit around 5 for a few more days. We'll stay ahead of it. He looked at her. They said you... He paused. They said you caught it when no one else did. I noticed something in the pattern. The surgical team caught it and fixed it. She meant this. The distinction was real, and she was not performing modesty. The noticing and the fixing were both necessary, and neither was sufficient alone. The other nurse told my wife you stayed an extra hour after the surgery to make sure the post-op monitoring was right. The monitoring setup was incomplete, she said. It needed to be correct. He looked at her with the expression of a person who recognizes when someone is refusing a compliment for reasons that are not false humility, but are something more specific. The insistence on describing the work accurately rather than heroically, because the accuracy is the point. Well, he said, it mattered. She picked up his chart and reviewed the overnight notes and asked him 4 clinical questions and wrote 3 things down and updated the morning medication schedule and did all of it with the same economy and care that she brought to every chart, every patient, every room. When she was done, she said, I'll check back at noon. She left the room and walked back down the corridor. At the nursing station, Patel was waiting with a coffee and the specific expression of a resident who has something to say and is composing the right version of it. About the note, he said. It's done, she said. You pushed it forward when it counted. I should have pushed harder the first time. Yes, she said, but you'll know that next time. He looked at her with the alert seriousness of someone writing something down in the part of their mind where the lessons that matter actually go. Then he nodded and went to work. She stood at the station for a moment and looked at the corridor, the ceiling lights, the scuff marks on the floor from 10,000 gurneys, the maintenance request she'd filed sitting in the bin, already in process. She had been dismissed from this floor 24 hours ago. She had been told she was outside her scope, operating beyond her designated position in a system that required everyone to understand their place in it. She had been handed a transfer order by a woman who meant it as protection and had used it as a weapon, under instruction from a man whose goal was to ensure that the one person capable of reading what was coming could not be in the room when it arrived. And she had stood at the lobby exit with the encrypted phone in her hand and turned around. Not because of rank, not because of the classified file or the dormant liaison status, or anything that was going to be in the formal reclassification documentation. Because there was a patient on the way, because the room wasn't ready, because someone needed to fold a note and put it in their pocket and act on it regardless of what the structure said about designated scope. She had learned, not in nursing school, not in any single place, but in the accumulated weight of years in which the designation had never quite matched the reality, that the most dangerous gap in any system is the one between what it permits people to see and what is actually there to be seen. Structures work when the people inside them are honest about that gap. They fail when the gap is used as a weapon against the person who is pointing at it. She was not going to stop pointing. She picked up the first chart of the day and began her rounds. The floor was busy and ordinary and full of people who needed things that mattered, and she moved through it the same way she had always moved, quietly, precisely, with the complete and unperformative attention of someone who understood that the work in front of her was the work that counted, that the title on the badge had never been the measure of the person wearing it, and that the greatest capabilities in any room were often the ones that had never needed anyone's permission to be real. She checked the wheel on the supply cart on her way past. Still bad. Maintenance request filed. It would be replaced by Thursday. Small things. The work. She kept moving.